Evening, sir. Good evening, all.
Monica will do the prayer and we'll start off with Jaideep ma'am's thing and then we'll do the rest of the formalities.
Yeah, sure.
Abhishek,
don't even introduce me.
Okay, ma'am. We are live now.
Good afternoon. Good evening.
Good evening all. I welcome you all on the behalf of Public Awareness Committee FOGSI with North Zone for the episode 4 of COR-Connect live webinar. MOC for the today's event are Dr. Monica Ubardhan and Dr. Shatabdi Dey. Ma'am, over to you for further proceeding, ma'am.
We welcome all of you to the fourth episode of the Public Awareness Committee webinar today. The theme for today is MTP and contraception. I would like to invite Dr. Priyankur Roy to give his comments and invite the guest of honor today.
Okay, thank you, Monica. It again gives me immense pleasure to welcome all of you to this Public Awareness Committee webinar. And today we are here to discuss the two very important topics of MTP and contraception. So this is the fourth episode of the program that we are having, and we are really excited to see so many people joining and so many people as well interacting, and we all benefit from this program. So today we have with us our chief guest, Dr. Rishikesh Pai sir, and our guest of honors, Dr. Jaideep Malhotra ma'am and Dr. Sudhara Pradeep ma'am. Rishikesh sir will join us in some time, but we have our guest of honor, Dr. Jaideep Malhotra ma'am with us. Thank you, ma'am, for joining us in spite of your busy schedule. I would like to introduce Dr. Jaideep Malhotra ma'am. Can we have her CV, please? So Jaideep ma'am is, as we all know, she is, I would say, as I tell Naren sir also, but Jaideep ma'am also similarly has headed all the organizations that we have actually heard of from our younger days. So she has been the past president of FOGSI, ISAR. She is she is currently the committee chair of a FIGO committee as well, and she is the immediate past president of SAFOMS, and she is also the vice president of INSARG. She is also the managing director of ART Rainbow IVF. So, ma'am, it's a pleasure you are with us, and I would request you for a few words of blessing to all of us present over here.
Thank you so much, Priyankur, and a very happy International Women's Day to all of you, and also happy Holi. It's just passed by, but we are still in the week. I'm right now addressing one of the corporates on Women's Day itself, and it's so nice, that to see all of you working towards a common goal which India needed all these years. And if we can actually take care of these unnecessary, unsafe abortions and can offer, contraception in the best possible way, I think it is one of the major milestones which our country is actually looking forward to. And I am extremely happy, and I congratulate to each and every one of you for choosing this topic, especially for the public awareness, because awareness is something which is lacking, to reach out to people. And I always say, educating doctors is one aspect, but educating lay public is the most important factor, because unless and until whatever we know is not really transmitted to the lay public, who actually is the actual beneficiary of our knowledge, we are not going to reach anywhere. So apart all these good work which you are doing, please look at public awareness at large for the public by each one of us, because that is our individual social responsibility, I would say. We have some corporate social responsibilities, but as an individual also we have a lot of responsibilities in furthering the cause. So congratulations and all the best for a wonderful webinar to go. Thank you so much for having me.
Thank you so much, ma'am. It's always a pleasure having you and always listening from you, the positive vibes that we get from it. Thank you, ma'am. So I'd just like to mention, ma'am, that we are the Public Awareness Committee under the FOGSI leadership and on the blessings of all of you seniors. We are doing the Anemia Mukt Nari project, and currently we have finished 1 week of the project as of now. As of now, till yesterday, we have tested almost 51,000 plus women, ma'am. That's one of the activities we are doing in collaboration with COR. So just wanted to mention that. And also, ma'am, of course, thank you for being here, and thanks for joining today, and thanks for your welcome.
Awesome. Keep on doing the good work. Very,
Thank you so
very
much,
proud
ma'am.
of you.
Thank you so much, ma'am. Thank you. So I would, since ma'am had to leave, I would like to now welcome all the others who are also present over here. And I did cut short the welcome address because ma'am had to leave. So I would like to thank, first of all, our president, Dr. Rishikesh Pai sir, for this opportunity, Secretary General Madhuri Patel ma'am, Alka Pandey ma'am, our vice president, and of course, our national coordinator, Dr. Kalyan Barmade. Our coordinators, Monica and Shatabdi, work day in and day out, and they have done a stupendous job again to bring all of you together in this wonderful webinar. Our conveners, Dr. Anita Sabarwal ma'am and Dr. Vidyu Motkil ma'am, it's always wonderful to have them. The support and the energy that they bring into every program is something that we definitely look forward to. So our guest of honors today, Dr. Jaideep Malhotra ma'am and Dr. Yashodhara Pradeep ma'am. Yashodhara ma'am will join us in some time, and Rishikesh sir from Dubai will again join us in some time. We have a talk on post-abortion contraception. The chairpersons are Dr. Dinesh Pathak and Dr. Meeta Gupta, and the speaker for this session would be Dr. Ashwini Kale. Panel discussion, we have two panel discussions, one on making MTP safe in high-risk pregnancy, and we have our moderators, Dr. Bharti Maheshwari ma'am and Dr. Vidhu Motkil ma'am, and the expert, the current MTP committee chairperson, Dr. Richa Sharma. Expert panelists for this session, Dr. Anupama Futela, Dr. Reema, Dr. Ritika, Dr. Chanchal, Dr. Sangeeta, Dr. Asha, Dr. Namrata, and Dr. Alka Yadav. We are indeed privileged to have all of you with us so that our knowledge can get enriched. The second panel is on cafeteria approach for contraception, and our moderators are Dr. Anita Sabarwal ma'am and Dr. Sonia Naik ma'am, and the expert is Dr. Naren Malhotra sir. We were supposed to have Dr. Kiran Guleria ma'am with us, but she is not well, and we wish her all the best to recover very soon. Our expert panelists are Dr. Shubha Pandey, Dr. Amrita Jaipuria, Dr. Shweta Mathur, Dr. Shalini Tandon, Dr. Vartika Kishore, Dr. Seema Hakim, Dr. Sugandha Chopra, and Dr. Gitanjali Kaur. So I welcome all of you to this session, and also thank and welcome Corona Remedies for allowing us or for offering the academic platform for this session. So thank you so much. I hand over the session back to Monica to kindly take it over.
Thank you, Dr. Priyanka. Even I cut short the entire introduction of this webinar. But now I would like to ask Shatabdi to introduce our other guest of honor, Dr. Yashodhara Madam. She has just joined. Abhishek, can we have Madam's slides?
Okay.
Shatabdi,
Yes, ma'am. Yes, ma'am. Just a minute.
A very warm welcome to everyone. A very happy Holi and happy Women's Day to all the wonderful ladies over here. It's my immense pleasure to welcome our next guest of honor today, Dr. Yashodhara Pradeep ma'am. Ma'am is, as we all know, she is the Vice President of FOGSI for the year 2023. She is the founder, professor, and head of department of the Department of Obstetrics and Gynecology at Dr. R.M. LIMS Lucknow. She is the senior professor at KGMU. She is the chief editor of JMH, and she has a teaching experience of more than 35 years. She has received various awards and honors from FOGSI and from various other government and non-government organizations, and she has multiple publications to her credit. We welcome you, ma'am. We would like to hear a few words of encouragement from you, ma'am.
Thank you, Priyanka, Monica, for inviting me for the program of Public Awareness Committee along with the North Zone. It's my pleasure to share the dais with President Dr. S.D. Pai, Honorary Secretary Dr. Madhuri Patel, the Vice President in charge of the Public PAC is Dr. Alka Pandey, and Dr. Kalyan Balmade, the previous chairperson, past chairperson of the PAC. This webinar is a very important webinar. We all know that 30% maternal mortality can be reduced only by safe abortion and by the contraception. Still, we all know that unsafe abortion is the third leading cause of the maternal mortality. So, my best wishes to Dr. Ashish Kale, who is going to have a first presentation, which is a very important topic. People do the MTPs, but forget to talk about the contraception. So post-abortion contraception is a pillar of the pillar to this. Is a pillar to MTP. If you have done any abortion for any rhyme and reason, If we have not provided the post-abortion care and post-abortion contraception is very, very essential. I'm sure that chairpersons Dr. Dinesh Pathak and Dr. Geeta Gupta is going to do the justice with it. The panels are very important. These panels making the MTP safe in high-risk pregnancy, because most of the time when the patient, the client comes to you, she is having previous abortion or previous cesarean section, she has conceived within 10 months or 8 months. These all are the high-risk situations. And we all are very scared, especially if she has come beyond 65 days of the pregnancy, because medical method cannot be given. You are monitoring well. You are taking precautions. You have investigated the patient. You have admitted her. You can do her, because this pregnancy, which has come after the abortion, within 10 months or within 8 months, is not going to do justice with the child who is there or with the mother also. Whatever the reason is, she has got pregnant. So, but the abortion is not the only way. You have to give them a contraception. Here, there is no limit. So, you can very well give her the injectable contraception, the Dimpa, for 3 months. And then you watch, see, monitor, and then give her some LARC method of contraception, because depending upon her choice, but LARC is a good method, because she did not want, it was the unintended pregnancy, so she has come to you for MP. So just make it sure that, and emphasize on her that you did not wanted this child, so you have done. So if you are going to use this, you will get the pregnancy whenever you want. It is always an intended pregnancy. Then panel on this, and there's none other than very, very expert people are moderating this panel, Dr. Bharti and Dr. Vidhu Mutyal. And Dr. Richa Sharma is the expert to this session. And there are various panelists, there are learned panelists are there. I can just see a few names. The Anupma Patela, there is a Rima, there is a Chanchal Gupta, there is a Alka Yadav, and there is a Alka Yadav, and there is a Namrata Bhardwaj, Asha Mishra, and Sangeeta. These are very important people who are going to address this panel. And I'm sure that all the audience is going to get the message, what is the outcome of it. Second panel is on the cafeteria approach, because initiation of the contraception counseling is by the cafeteria approach. This is a very important thing, because initiation is very important. Then method specific counseling can be done on the individual basis. But to start the counseling, and here I can see that the moderator are very learned people, Dr. Amita Sabharwal and Dr. Sunita Nair, and Dr. Naren Mehrotra, past president, is going to be expert for this session. So it's a wonderful, Dr. Mehrotra, to be there, and I'm sure your advice is going to be wonderful. And all the learned panelists, Dr. Sridhar Pandey, Dr. Anita, Dr. Shalini Chandan, Dr. Geetanjali, Dr. Vartika is going to be an excellent panelist. Therefore, I am sure that my best wishes are with you, and I am sure this webinar is going to bring out many important points. So the woman is going to use how, when the high-risk MTP can be done in the high-risk pregnancy, what contraception can be given, and the initiation of the contraception, and it is going to be very nice. Thank you so much for inviting me.
Thank you. Thank you for your blessings, ma'am.
Thank you, Yashodhara ma'am, for your blessings and for the wonderful message. Thank you for being here, ma'am. Now I would like to.
Yes, I'm going to board the flight just now.
I would like to welcome two more very important people who have worked very hard and who have given a lot of colors to this webinar. And I would like to welcome specially again Dr. Narendra Malhotra sir, who is always there and always there with all of us in our activities. And he has thankfully, and he has agreed and he has thankfully judged all the slogan competition. Actually, we had a Women's Day competition and that was on women empowerment. And we had a slogan and essay competition that was conducted. We received almost 65 slogans and sir went through each of them and he has judged all of them. And for the essay competition, we had Dr. Charulata Bapai who has judged them, and we had 55 entries for the essays as well. So thanks to all the participants who have put in their effort in submitting their entries, and the awards will be announced by our judges. And I would request Shatabdi to kindly introduce the judge, and then after that the results will be announced.
Thank you, Priyankur. A very warm welcome to Dr. Narendra sir. Hello. Yes, can I have the next slide, Abhishek?
Yeah, Monica.
Narendra sir is the past president of FOGSI. He is the most approachable senior most gynecologist of Agra, and he's a practicing consultant at Rainbow Hospital. Sir, we invite your thoughts about the slogan competition, please, sir, before we declare the results, sir.
A very good evening to all of you. Yeah, thank you. Thank you very much for inviting me here to judge this very, very important aspect of women's health. Happy Women's Day to all of you. We had a great panel and discussions of FOGSI yesterday on Women's Day and on women. And one question which arose yesterday in the debate, which people were saying both and yes or no, where do women's problem lie, in the men or in women? Now, to be on the lighter side, women, the word women has men in it. The word hysterectomy has his in it. The word female has male in it. So all the problems of women are the man or the male or the his is right into it. So we acknowledge we are the problem in women's life, but still we cannot do without them. The women are women. And being a ladies apostrophe as doctor, I have been involved with so many women right from the beginning of my career. And it's been an interesting life of a gynecologist, which my life has been. So congratulations on this International Women's Day. It is celebrated every year. It was first celebrated on 28th of February initially, then the date was 19th. And from 1975, I think, it is 8th of March by the United Nations, which declared it as the International Women's Day. So congratulations, all the best to all the women. There are just one more thing, four E's, which are the women's problem. We have the word weep, no, W-E-E-P. My word weep is with 4 E's, W-E-E-E-E-P. So the first problem is education that we are tackling. The second problem of women is employment after getting educated. The third problem is the environment, a safe environment all around them. And of course, final problem, finally, is the empowerment. So women are educated, women are getting employed, not as that much. Women's environment is still unsafe and women are still not empowered enough. So we need to tackle this weep with 4 E's to make women stand right next to us and to give them a status. Thank you once again. It was very difficult to judge this. 60 entries and entries from ward nurses, from junior doctors, from JR1s, JR2, right up to consultants, entries in 2-line slogans, entries in poetry, entries painted, and I could shortlist 16. And then out of the 16, finally, we shortlisted these 3 or 4, which will be just announced to me. Congratulations, Priyankur, for doing this activity very, very beautifully.
Thank you, sir. Can we have the slide, please, so that we can announce the results? Sir, we would request you to kindly do the honor, sir.
Abhishek, the next slide, please, so that we could announce.
So the slogan competition winners, congratulations to all of them, are Anita Malik. Anita Malik has participated in and she gets one of the prizes for the best slogan.
Third
Third
prize.
prize.
Third prize. And you look at her slogan, Nari ko surakshit atmanirbhar bana, सशक्त अधिकार एवं पहचान दे, सम्मान सुरक्षा पाए हर जननी, वो सुखमय परिवार स्वस्थ राष्ट्र का आधार हो. Anita Malik from SOGS. Well done, madam. The second prize goes to Shikha Sharma, and her slogan is, you see, sans ailment, she can soar so high, contribute to her agility and make her touch the sky. So that is it. And this is a GR1. I'm sure of Unit 4 Janana Hospital. Shikha, I'm sure you wrote this while you were doing the night duty and in between delivering babies. I know Janana Hospital delivers almost 20-30 babies in the night. And looking at your writing and everything, I'm sure this has been done while delivering babies. All the best. Thank you very much. Congratulations. And Neelam Singhal, of course, gets the first prize. Neelam's slogan has been, Bahu beti maa bankar sukh dukh ka sahkar, sab farj nibhati hai, tabhi nari kehlati hai. So that is from Alwar and Alwar Society. I'm very, very impressed by this society. Small society, and it does phenomenal amount of work. So Neelam, if you are listening to this, I am a big fan of Alwar ka khoya. So next time when someone is coming, please send me a basket, वो लकड़ी की basket में अलवर का भुना हुआ खोया आता है ना, वो जरूर भेजना. First prize to you. Congratulations. Special appreciation. See, again, Alwar, they had the maximum entries, and it was so difficult deciding Monica should be first or so both of them. So we give a special appreciation. कर दो ये फरमान जारी, अब मैं सशक्त हूँ ना बनूंगी अबला नारी. That is what women are. नहीं बनूंगी अबला नारी. Monica, congratulations, and looking forward to meeting you very soon somewhere.
Thank you so much, Naren sir. That was indeed wonderful to judge so many entries. It's indeed a matter of pleasure for us that you have joined us and you have also announced the prizes. Thank you so much, sir. I'm sure it means a lot to all the winners. We also now have with us the Rishikesh Pai sir, who is the chief guest for today's program. And we are so glad that sir could join us for today's program. Sir is busy in a meeting in Dubai, but he made it a point to join us. So can we have Rishikesh Pai sir's slide, please? He's currently the president of FOGSI. He has been the past president of ISAR as well as IAGE. And sir is the medical director of Bloom IVF, and he has been awarded a number of fellowships. He has served FOGSI in various positions and posts. And as we know, he is known to be a person with inclusive person, giving chances to many, including many juniors like us. So, sir, it's a pleasure you have joined us. Requesting you to kindly say a few words.
I'm really happy that you are doing this wonderful program. Priyankur is our new chairman, and in a short span, he has created a lot of impact. The Public Awareness Committee has done great amount of work, and this is the North Zone. With the North Zone, he is doing this program, and there are a lot of seniors that are there. I can see Dr. Narendra Malhotra and Dr. Jaideep Malhotra, Dr. Yashoda Pradeep are there as well. And I don't know whether Madhuri has come and joined, but there are a lot of others like Anita Sabarwar I can see, and many others are there. As you know, I'm actually in the Dubai meeting. It's a very privileged because the first time this is the first guidelines on PPH were done in 2012. And there have been 3 modifications, and now this is the big group. First time, we are being called, and there's a lot of public health people. I'm seeing how the guidelines are being formulated. This is the 3rd day of the guidelines being done, and it's quite a revolution. And let us hope we are also doing our 35 guidelines are being done in our country, and every time it's a learning experience because. You see how these people, they formulate it, how the groups are broken into, how they devise it, what is the consensus, So it's a new kind of exposure, and that we should apply to, of course, I'm being very, down the same because I don't want, see the problem is that internationally we should not be looked upon as aggressive people. See, what happens is we become very aggressive. So we have to make it we have to smoothly enter the international arena so that they accept us as a part of their because of course we are a large country, of course we are 1.4 billion people, of course we have 30 million deliveries, but that doesn't mean that some small country which has got 1 million deliveries is lesser than us. So this is what we Indians have to understand, because we come from very difficult backgrounds. In those early days, we always struggling. Slowly, we became bigger. We have now established ourselves. But with that, we also, without our knowledge, we start becoming more subconsciously more aggressive. And, which is a part of our DNA, because we have struggled very hard to achieve this. But in that process, that aggressiveness can be a negative thing. So this is what I would like you all to understand. So now that we are come of age and we are now going to the next level of international participation, we have to be more lesser aggression will take us longer, further distance. And that is what we have to, that is a learning process. And see, what is my role as a FOGSI president? My role as a FOGSI president is to see that all of you are going up in the international, all of you progress. This is what I'm a facilitator for you to achieve further growth, because this I always tell everyone, that we must have continuity. We must nurture our younger people and push them forward. It is very difficult to do it. It's a big sacrifice when you have to give way to, and so you sit down so that others can step on your head and climb. That is the ultimate achievement of success, in my opinion. And that is what we have to learn. We should learn to give to others and to nurture and to push our young people, like Priyankur is there. Young people like him has to go further. So anyway, I'm very happy that you're having this program, and you're always there in my heart. Ultimately, I'm what I am today is because of the Mumbai Society, ultimately because of FOGSI. All of you, you vote for us, you respect us, and we are nothing without all of you. Remember that. So when we are a part of you and you are a part of us. So I'm very grateful and thankful to all of you, and wish you the very best, Priyankur.
Thank you so much, sir, for joining us, first of all, and for your encouraging words. It means a lot to all of us. Thank you so much once again, sir.
Thank you.
Now, thank you, sir. Now I would like to request Monica to kindly introduce Charulata Papai ma'am to announce the prizes for the.
Abhishek, can we have the slide, please? Charu ma'am is currently the FOGSI Breast Committee chairperson. She's also the director at GMS Hospital and Endoscopy Center at Pune. She is also an honorary consultant at Dinanath Mangeshwar Hospital. She's academically very inclined and has national and international papers to her credit. Yet so humble and approachable, she said yes at the first instance when I met her in Sholapur here. Thank you so much, ma'am, for accepting our invitation. Please let us know about your experience for judging this essay competition, ma'am. Before you can declare.
Thank you so much for the starters. Thank you very much. So the outset, I would like to congratulate Dr. Priyankur Roy, chairperson of the PSC, and you as an able assistant to Dr. Priyankur for having thought of this particular competition. It is indeed rather difficult to speak after Dr. Narendra Malhotra sir and Dr. Rishikesh Pai sir. But let me tell you that I was indeed honored when you asked me to, judge this particular essay competition on women's empowerment. I thought that what a lovely idea to think of. What a nice way to involve everybody. And another thing that I realized is that when we write something, we tell it to ourselves also. Just as when I read it, I started looking at the different ways in which I can empower myself in a better way. And I can, spread this message of empowerment to my patients also. Indeed, it was a pleasure judging this competition. I think the ideas which were put forth by all the writers were amazing. I could see that the entries were from so many societies, some small, some big, some medium. And as you know, some were from government hospitals, some were private practitioners, but all of them talked about women's rights, equality, reduction of maternal mortality, right to safe motherhood, and very importantly, there were so many others who spoke about the current theme of this particular International Women's Day, which was digital. That means digitally. I think women should make sure that they use the digital media, social media, and so many other apps which are there available today to make their lives a little simpler. They have balanced their lives as far as their family is concerned, their career is concerned, their children are concerned. Many apps or so many methods by which they can remind.
I guess we just lost Charumam's signal. Yeah, Monica?
Yeah. She's still there, but I think she's lost her signal. In the meantime, Priyanka, can you declare the results? Abhishek, can we have the next slides?
Yes, ma'am.
Charu ma'am, yeah, she's joined back. Charu ma'am.
Ma'am, can you unmute yourself?
Can you hear me?
Yes, ma'am.
Yes, ma'am, we can hear you. We request you to switch off the video, ma'am. Then I think it will be a little better.
Your voice will come clearer,
So
ma'am.
I
You
don't
switch
know.
off the video.
Can you hear me now?
Yes, ma'am.
Yes,
We
ma'am.
can hear you. Just
I think let us move ahead with the results. Hello?
yes, ma'am.
Yes, ma'am. We can.
It was indeed
Yes.
difficult.
Charu ma'am, please go on. We can hear you.
Congratulations. I think I'm in a poor signal zone. I'm really sorry about this.
We can
But
hear you clearly now, ma'am. Please go on.
Heartiest congratulations to all the winners.
Ma'am, you can announce the results. We can hear you now. Priyanka,
Charulata ma'am, result is on screen, ma'am.
Okay. So if ma'am is not there, okay. So I would just like to announce the results for the essay competition. First of all, I would thank Charu ma'am for judging it, for judging this 55 plus essays which has been submitted. And she has done, I am sure she's put in a lot of effort, and she was smiling at the end of reading 55 essays. That's something that is really wonderful. So the third prize for the essay competition goes to Dr. Ashmita Yadav. So I would like to congratulate her. Thank you so much, ma'am, for participating, and continue participating, please. It is not easy to be a pioneer, but oh, it is fascinating. And that was a punchline from Dr. Asmita Yadav from Manipal. Congratulations, ma'am. Next slide. The second prize, we have two third prizes. The third prize goes to Dr. Charu Khodliwal, ma'am. So congratulations, ma'am, for participating, and we request you to kindly continue participating. She talked of how women professionals can help in women empowerment, and it was a wonderful essay. Congratulations, ma'am. Next slide. The second prize goes to Dr. Sairindri Sahu. Congratulations, Dr. Sairindri Sahu. The prize winners get, the second prize winner gets a beetle Doppler that will be given by Corona Remedy. So thank you, Corona, for supporting our activity. And she is from Behrampur. And the prize, congratulations for participating, and request you to kindly participate. And the best part is she is the third year PG resident, and finding out time to write an essay during a third year PG residency is something that is wonderful. Congratulations once again. Next slide. The first prize goes to Dr. Abir Sarkar. Congratulations, Dr. Abir, for participating. We are really thankful for the essay that you have sent in, and request you to kindly continue sending. Dr. Abir is from Faridabad, and congratulations once again. Next slide. We have a special appreciation prize as well, and special appreciation prize for the essay goes to Dr. Palak Bansal. We would like to really congratulate Dr. Palak as well for continuously participating. And as far as I remember, in the last competition as well, she bagged the first prize. So congratulations, Dr. Palak from Bhopal. Continue participating. So I'd like to thank and congratulate all the winners for participating. And the biggest winner is the one who participates. And so congratulations to all who have participated at large. Thank you so much. Over to you, Monica, to take ahead with the scientific session.
Thank you, Dr.
Monica ma'am, you are on mute. Kindly unmute.
Thank you, Charu ma'am, and thank you, Narendra sir, for judging our competitions. And we also thank all the participants who have actively participated in all the competitions hosted by Public Awareness Committee. We now move forward to a scientific session, which is a lecture by Dr. Ashwini Kale madam. The chairpersons for the scientific session are Dr. Dinesh Pathak sir and Dr. Meeta Gupta ma'am. Dr. Dinesh Pathak sir is working as a senior division medical officer at Firozpur, Punjab. He is also the president of Firozpur OBGY Society. He is the founder secretary of the society. He has special interest in high-risk pregnancy and maternal mortality, as well as minimal invasive surgery. He is a part of the scientific program of the state and national conferences. He's presented and published many papers in various journals. We welcome you, sir. Our next chairperson for today's session is Dr. Meeta Gupta madam. She has done an advanced course in medical education, professor and head of the department at AIIMS, Vijaypur, Jammu. She is also the member of the State Motherhood Committee, FOGSI, and she has been a postgraduate teacher for the last 17 years with special interest in adolescent health and high-risk pregnancies. We welcome both of you to chair the academic session, talked by Dr. Ashwini Kale ma'am.
Yeah, thank you.
So you can go ahead for the introduction of the speakers.
Should I introduce Dr.
Yes, sir, you introduce. The slide is being projected.
Yeah. Okay, good evening, everyone. So,
Dr. Ashwini Kale.
Dr. Ashwini Kale, she is a chief embryologist of ASA Ken Hospital and ASA IVF Center, Arunachal Pradesh, Hyderabad. She is secretary, Pune Ops and Gynae Society. She is treasurer, Maharashtra chapter, ISHAR. She is elected MC Embryology, ISHAR chapter for 2020-24. She is MCA Maharashtra chapter, ISHAR 21-23. She is chairperson of AMOGC Young Talent Promotion Committee 21-23. She is the general coordinator of AMOGC 2018-2020. She is also peer reviewer of Jogi, our journal of FOGSI till date. And she has been awarded with FOGSI Sun IACA Traveling Fellowship in 2021. And she also winner of FOGSI Santi Yadav Award 2022. So she will be talking today on the post-contraceptive pills. Post-abortion
Thank
pills.
You so much.
And all the contraceptions after post-abortion. Thank you. Over to you, ma'am, please.
Yeah. Thank you so much, sir, for the introduction. First of all, heartiest congratulations to Priyankur and Monica for this wonderful webinar and for having me here. I must say that as a national coordinator, this is my first talk today for the Family Welfare Committee. Thank you once again. So my talk today is on post-abortal contraception. Yeah. Is the screen visible?
Yes, ma'am.
Yeah. Yes. So according to this Indian incidence, the abortion and unintended pregnancies in India in 2015, total pregnancies are about 48 million, and of which about 80,000 pregnancies are still unintended. And these unintended pregnancies have undesirable consequences. And because of this, we have post-abortion contraception, which is so important these days. Because this leads to unwanted childbearing, it can also lead to unsafe abortions because the couple may not want the pregnancy. And there is a lot of morbidity and mortality which is associated with this, not only to the mother, but to the newborn and to both of them. Unintended pregnancy is a strong indicator for the need for improvement in contraceptive services. Post-abortion contraception, about 70% of women were not using any method following abortion. And 1/3 of these women were using a contraceptive method after abortion. Almost 24% used condoms, 27% traditional methods, 20% oral pills, and only 7.9%, that is about 8%, were using IUDs. Most women reported not starting any contraceptive usage within the first 2 months after abortion, thinking that they may not get pregnant or there is no need once the abortion is done. 14% had prior abortion experiences, hence they were confident that they would not want to use it again. Abortions account for approximately 8% of maternal mortality in India still, and family planning can prevent 90% of this mortality, which is associated with unsafe abortions. So these are the I'm sorry. These are the various methods that are available, of which the most effective, that is less than 1 year of pregnancy, are the implants, which have come again in a big way. And reversible contraceptive, another option would be your intrauterine device. As far as permanent method is concerned, post-abortal male or female sterilization both work equally well, but then you need a lot of motivation for the patient, and the family has to be completed by the couple to go for the permanent method. Other methods are injectables, OC pills, or progesterone only pills. There are various patches, rings, or diaphragms, and other options would be male and female condoms, the withdrawal method, or the sponge method. Now, coming to the various options, oral contraceptive pills is the most easily available option and the most acceptable option also because of ease of use. Then there are only progesterone only pills, which are easier to use in breastfeeding women, vaginal ring for the convenience of it, LNG IUC, long acting but reversible, and injectable DMPA is also very convenient with a 3-monthly use. Contraceptive counseling. Now, this is another very important part of contraceptive advice, because this is the right chance when a patient comes to you seeking abortal advice that you can actually advise her for further contraception. So why is the need for this post-abortal contraception? Because the woman receives the post-contraceptive abortion assistance to allow 6 months of minimal inter-pregnancy interval. So it is also good for her to delay her further pregnancy, which may be intended or unintended. And ovulation returns as early as 8 days following an abortion, whether it is medical or surgical, and almost 83% of women ovulate following the first cycle of an abortion. So the woman has to understand that even the next cycle she may ovulate and she has an equal chance of getting pregnant. Ministry of Health recommends that contraceptive methods should be available at the same health facility where they receive care during the abortion process. So it becomes easier for the women to come back again and to at least avail the facility or have an access to any of the contraceptive choices that are available now. Now, return to fertility after abortion. After the first trimester abortion, even after vacuum aspiration, the women can ovulate as early as 10 days. And after medical methods of using mifepristone and misoprostol, on an average, the fertility returns or the ovulation returns within 20 days, and she can ovulate as early as 8 days. After the second trimester abortion, after medical methods, within 4 weeks. Now, counsel the women for informed choices before she leaves the health facility. This is very important. If she chooses a family planning method, well and good. We have to help her initiate the method of her choice, because just motivating the couple is not enough. We have to give her the options and also motivate her to initiate it as soon as the abortion is complete, because many a times women do not even return after the contraception, after the abortion is over, whenever you give them medical method of termination. If the couple or the patient is not able to decide on any family planning method at that time, or if she's not eligible for one certain method, you can always schedule a follow-up within 2 weeks or give a referral appointment at her nearby family planning facility. Or you can always take her contact number and send a reminder message within 2 weeks. Now, what are the different methods of contraception that are available? Depending on the timing of after abortion, that is whether it is first or second trimester, condom is the safest, easily available and accessible method. As soon as sexual activity is resumed, one can start using the condoms. There are no hormonal side effects. It can be used even without consulting a healthcare provider. It also prevents against STIs, including HIV, and it also enables the men in the family to take the responsibility of contraception. Diaphragm and cervical cap are not recommended until after 6 weeks after a second trimester abortion, when the uterus returns to the normal size. And whenever you find that there is an associated risk of any sexually transmitted infection or HIV, it is important that dual protection is recommended. Coming to first trimester usage of COCs, so immediately or even up to 7 days after abortion, the best way is when you prescribe medical termination. It can be given on the day 3 or the 3rd dose of misoprostol. That is your 3rd day. And immediately the patient can be assured that it will start working. Progesterone only pills are given in those patients who are breastfeeding immediately or up to 7 days after abortion using surgical methods. And with medical method, it can be started on day 3 with the dose of your misoprostol. You can assure the patient that this will not interfere with her abortion process. So what is the additional advantage of using this? That it will also regulate her menstrual cycle. It does not interfere with sexual intercourse. It offers protection against ectopic pregnancy, endometrial ovarian carcinomas, though the progesterone-only pills are to be used in breastfeeding women. And these can be provided by the healthcare provider immediately whenever the patient comes to seek abortion. There's immediate return to fertility, does not interfere with the sexual activity, and it is safe in breastfeeding. That is the progesterone-only pills. Then Croman, it can be used immediately up to 7 days after abortion using surgical method. And with the MMA, it can be given on the day 3. It is safe for breastfeeding women. There's immediate return to fertility. It cannot be given in women who have cervical hyperplasia, tuberculosis, or renal diseases. Now coming to long-term injectables, that is medroxyprogesterone, that is DMPA, these are also available at all the PHCs. It can be given with medical management of abortion started on the day 3 along with your misoprostol dose. And in second trimester, it can also be given immediately or up to 7 days after abortion. It is highly effective. With DMPA, there's an Antara program running. So there's a confidentiality and privacy maintained. You do not have to carry it like the pills. It is given once in 3 months. It does not interfere with sexual intercourse. There are no estrogenic side effects. It does not have any effect on the quality or quantity of breast milk, and fertility returns within 7 to 10 months from the last dose of the injection. And during the times of COVID, these injections were also self-administered by the patients. So they are pretty safe. If the contraception of choice is OC pills, PO pills, Croman, or injection DMPA, you can start it after your medical or surgical first trimester abortion. And it does not affect the efficacy of the abortion process or the post-abortion bleeding. If started within first 7 days of your first or second trimester miscarriage or induced abortion, there is no need for any backup method. And if it has been more than 7 days after your first or second trimester miscarriage or induced abortion, we need a backup for the first 7 days for OC pills, injectable DMPA or Croman, and for the first 2 days in cases of progesterone-only pills. The other method is IUCD, which is a long-term reversible method. You can insert it immediately or up to 12 days after confirmation that the abortion is completed, because at times if it is an incomplete abortion after medical management, you cannot fit in immediately. So an ultrasound is needed once the abortion is complete. And with medical method inserted around 15 days of the process, provided that expulsion is complete. After the second trimester, it can be inserted immediately or up to 12 days after the procedure is complete, after contraindications are ruled out. It is highly effective. It can be inserted for up to 5 to 10 years. 10 years IUCD 380A is inserted. There's no interference with the sexual activity. There's immediate return to fertility as soon as it is removed, and there are no hormonal side effects. If the contraceptive is your IUCD, a backup method is not needed if it is inserted within the 12 days after the first or the second trimester spontaneous or induced abortions when there's no infection. If it has been more than 12 days after the first or second trimester and no infection is present, an IUCD has been inserted after it is reasonably ascertained that the woman was not pregnant. If infection is present, you can always treat and refer the woman or choose any other method. If insertion is delayed, always give a backup method. IUCDs are superior to user-based method as they do not rely on any adherence. Coming to female or male sterilization, these are the most effective methods, and they can be used post-abortal after an abortion in the absence of any infection, or if there are no complications like severe blood loss, or up to 7 days. Both mini-lap and laparoscopic sterilization can be done. With MMA, it can be done only after the first menstrual cycle, so that we are rest assured that the patient is no longer pregnant or it is not an incomplete abortion. Vasectomy, it can be performed on the male independent of the timing and procedure of the abortion. Probably when the woman comes to seek advice for the abortion, it could be a time to counsel the male in the family, or at least offer him this option of vasectomy. It is very effective. It does not interfere with the sex, no long-term health risk, and the couple must use another contraceptive method for at least first 3 months or till there is azoospermia. And you also have to counsel the male saying that it does not affect, though it causes azoospermia, it won't cause any erectile dysfunction in the male. Coming to emergency pills, it is an important backup method when contraception fails or the condom breaks, or when there's no method is used, or when there is forced sex. Providing emergency contraceptive pill in advance as a backup method may help prevent future unwanted pregnancy, but we have to be very cautious when we prescribe them, because we have to tell them that these are emergency pills to be used only when and needed in emergency. It cannot be a routine contraceptive method. It does not offer any protection against STIs or HIVs. Generally, it is less effective than other contraceptive methods, and it may have side effects like nausea and vomiting, and there may be a longer period of amenorrhea or spotting induced. Contraceptive counseling and provision should be an integral part of abortive care or post-abortion care to help women avoid unintended pregnancies. Contraception should be started within the first week of an abortion, as ovulation may occur as early as 8 to 10 days after an abortion. Immediate start of contraception following medical or surgical first trimester does not affect the abortion process or the post-abortal bleeding. So you can prescribe oral contraceptive pills on the 3rd day of your abortion or the 3rd dose of your misoprostol. Long-acting reversible contraceptive methods are the most effective contraceptive methods to help women avoid repeated unintended pregnancies. Thank you so much for your patient listening, and congratulations once again, Priyankur and Monica, for this wonderful webinar.
Thank you, Dr. Ashwini. I think so. You were great in your presentation with very crisp and take-home messages. I think so. The Public Awareness Committee has really done a tremendous job for picking up this topic, because it gives us an insight that once the patient comes to us for this abortion, this gives us a window of opportunity to, just catch hold of these patients. And if we look at one of the programs of Government of India is Chaya, in which they are specially, taking care of Sencromen, because it is just twice a week in the initial stages, and that is what the patient is very receptive. True. But it has not come in our practice probably of all the guidelines. Right. Yes. So I think so. This Public Awareness Committee has done a tremendous job. First, in that screening of 51,000 patients, females for anemia MUC. And this is the second into their initiative, that if we offer them post-abortional care, so it would be. So hats off to Priyankur, Dr. Monica and Shatabdi for really coordinating well and choosing the topics. And, Dr. Ashwini, hats off to you. You really presented your topic with such much crystal clear message. Thank you so much.
Thank you so much. Thank you.
Dinesh sir, would you like to add on something?
Yeah, this is the window opportunity when we get the opportunity, when we can ask the patient to take the contraceptive measures, because most of the time they won't come to you on regular basis for contraceptive choices. So when they come to us, we can have the proper contraceptive methods. What are the side effects? What are the positive side effects? What are the positive things which we can helpful in the, because most of the infant mortality is still because of the unintended pregnancies. So this way we can also reduce the maternal mortality also, which impacts the maternal mortality. So we should not miss this opportunity to counsel the couple and provide them the necessary contraception, so they do not suffer from unintended pregnancy and miscarriages. Yeah.
I think only after they go through the painful procedure of a surgical abortion, maybe that is the time that they are very receptive for contraception. Otherwise, as a routine OPD, they will never come for seeking for any advice. And government has also come up with many schemes. So that is also a very good thing where it is accessible and available to them.
Yeah, even they refuse, we can counsel them to come after few weeks, 2 weeks, so that after that they think settles, the emotional sets, and they can accept the whatever we are offering them. So yes, they can have understanding at that time also. So we should not miss this even during the follow-up. So we should have we should try all our level best whenever we get contact with such patients to provide them the contraceptive methods, to adopt them any contraceptive method which is better for them. And it is all the good and counselings to them. Yeah. Very nice. Questions will be dealt later on if time permits.
Yes, sir. Thank you so much, Dinesh sir and Neeta ma'am, for sharing the session. Ashwini ma'am, it was a very crisp presentation. And as you very rightly said, women are more receptive in the post-abortive period. So it is the best opportunity to counsel them. And cafeteria approach needs to be provided to select the contraceptive method. We now move forward for the next academic session, that is the panel discussion on MGP. For this panel, we have our moderators, Dr. Vidhu Modgil madam and Dr. Bharti Maheshwari ma'am. Vidhu ma'am is also the convener of this program. Our expert panelist is Dr. Richa Sharma ma'am. I take pride in introducing Dr. Bharti Maheshwari ma'am. Abhishek, the first slide, please. She is the professor and head of the department of Muzaffarnagar Medical College. She also holds a diploma in IVF and reproductive medicine in Germany. She has been the past chairperson of FOGSI MTP committee from the years 2018 to 2020. She also has a fellowship in medical education. She is also the governing council member of ICOG and the organizing secretary of UPCOG. She was the president of Meerut OBGY Society. She's authored many textbooks. She has been academically very interested and presented many national and international papers, as well as review articles and index journals. We welcome you, ma'am. Our next moderator is Dr. Vidhu Modgil, madam. She is a director and senior consultant at Suman Hospital, Ludhiana. She has her affiliations including FOGSI, ISAR, SOFOG, and IFS. She is the past president of Ludhiana OBGY Society, has also been the past secretary of the same. She is a life member of NACHI. She is received many awards in organization.
We can just start the session, Monica.
Yes, ma'am. Ma'am, you would like to introduce the panelists, or should I introduce them, ma'am?
हाँ, चलो panelists को आप कर लो.
Yes. Our expert panelist is Dr. Richa Sharma, madam. She is currently a professor of OBGY at the University College of Medical Sciences and GTD Hospital, Delhi. She is currently the MTP committee chairperson from the year 21 to 24. She is a national corresponding editor of Journal of OBGY India from the year 21-24. And she is also the IIG managing committee member. We welcome you, ma'am. Our panelists for today's session include Dr. Anupama Fatela, ma'am. Can we have the next slide, Abhishek, please? Am I audible?
Yeah.
Madam has graduated from the Lucknow 1987 KGMC batch. She's a master from NEMC in New Delhi. She's also a fellow in reproductive medicine from NUH Singapore. She is the senior consultant at Fatela Hospital, Rudrapur. The president of the same society currently, an executive member of National FOGSI Endometriosis Committee, as well as an executive member of Uttarakhand Society of OBGYNs. We welcome you, ma'am.
Thank you, Monica, and we can move. Yeah, thank you.
Our next panelist, Dr. Reema Khajuria, ma'am. She is a professor and unit head of the Department of OBGY, Government Medical College, Jammu. She's her affiliations include IMA, the Medical Education Committee, FOGSI, and she has been the secretary of Jammu OBGY Society. Her special interests include gynec oncology and high-risk pregnancy. She's an undergraduate and a postgraduate teacher and guide, and has various publications to her credit. We welcome you, ma'am. Dr. Ritika Agarwal, ma'am, is an associate professor at Venkateshwara Institute of Medical Sciences, Gajraula. She holds a fellowship in reproductive medicine and a diploma in ultrasound from Jefferson University. She has over 8 years of teaching experience. She is the joint secretary of Moradabad OBGY Society. She has keen interest in IVF, infertility, diagnostic laparoscopy procedures, ultrasound, obstetrics, and infertility. She has been a faculty in many national and international conferences. We welcome you, ma'am. Our next slide panelist is Dr. Chanchal Gupta, madam. She's currently the HOD and senior consultant of obstetrics and minimal invasive surgery, Asian Fidelis Multi-Speciality Hospital, Faridabad. She has been the organizing secretary of MTP-Con 2022, secretary at Faridabad OBGY Society. She is the executive member of Haryana chapter IIG and the organizing secretary of PH 2018. She has her keen interest in high-risk obstetrics and gynaecology. We welcome you, ma'am.
Thank you. Thank you.
Our next panelist, Dr. Alkaya Adumani. She's a consultant gynecologist at Shanti Hospital, Narnaul, for the last 28 years with special interest in high-risk obstetrics. She is the president of Revari OBGY Society, a member of FOGSI Public Awareness Committee, the Best Paper Presentation Award at UA FOGSI on adolescent tumors and role of magnesium in preterm labor. She is the vice president of Women's Association Haryana and the vice president of IME Narnaul. We welcome you, ma'am. Our next panelist for the same panel is Dr. Namrata Bharadwaj, ma'am. She's a gold medalist in MD and she's from GNMC Aligarh. She's a consultant at Bharadwaj Nursing Home and she's an assistant professor, JN Medical College, Aligarh. She has won various awards for paper presentation in conferences, and she's also delivered the family law operations at the National Conference. We welcome you, ma'am.
Thank you.
Dr. Asha Mishra Madam is a Professor Emeritus and former head of the Department of OBGYN Society with the National Institute of Medical Sciences, Meerut. She has graduation from her King George Medical College, Lucknow. She has done her observership in the Department of Fetal Medicine at Louisiana University of Health.
His work is I can take on if Monica's, I think so, network has gone. So worked as a consultant in London Hospital and IVF Center, Kuwait for 8 to 7 years, presented many papers. She has special interest in fertility and she's a president Hapur Obstetrics and Gynecology Society. Welcome you, ma'am.
Thank you, ma'am.
Then Sangeeta Agarwal, she's an associate professor, Government Medical College, Patiala. 20 years of experience in OB and Gynae. Areas of interest is high-risk pregnancy and menopausal health. National trainer, Rashtriya Kishore Swasthya Karyakram. Life member of all the Indian IMS, FOGSI and other societies. And she's a nodal officer also. Welcome, Dr. Sangeeta.
Thank you. I am Dr. Bharti. Yeah, with Dr. Vidhu, we are going to have in next 30 minutes some very important panel what we are going to have, and that is the safe MTP practices in high-risk women. So Vidhu madam, you want to start, please?
Yeah, thank you, Dr. Bharti, for sharing your slides with me. And I'll welcome all the panelists. And it is a very informative session. So let's take everybody's opinion and get to some point. So we'll initially talk just about what is the global challenges in MTP. They say about more than 5 lakh women die annually worldwide from pregnancy-related causes. 63,000 women die each year as a result of unsafe abortions. And 5 million suffer temporary or permanent disability as a result of an unsafe abortion. So India, every day, 13 women die in India due to unsafe abortion-related problems. Nearly 15 million pregnancies are terminated every year in India, and unsafe abortion, the third leading cause of maternal deaths in the country. Still, you know, with so much advances, we see abortion is a main cause of death in our country. So why, seeing this, MTP Act was created, which wanted to decrease the less of maternal deaths. To decrease it, that the component of comprehensive abortion care was done, in which there is counseling, clinical assessment, pain management, uterine evacuation, managing complications, post-abortal counseling and follow-up. And for post-abortal counseling, we say that's the best time to counsel a patient to take a contraception because she's gone through a very painful procedure. So what are the essential and protocols? Can I, last slide, please? इससे भी पहला वाला. Essential protocols of safe and legal abortion is performed by RMP as defined under MTP Act. It is performed at an approved site under the Act and it should be recorded. Other requirements of the Act as consent, monthly reporting, the pregnancy, its registration improved by the law. And this is important for all the medical centers which will have to be registered to get an MTP done to have a safe abortion time. Next. So we will just talk, we'll take few cases by Dr. Bharti. She'll take on the cases. Dr. Bharti, we can continue with the cases.
So good evening everyone, and as Dr. Vidhu has introduced the importance of topics, that why we have kept this topic, though abortion is a thing what is a very common, and we all know that MTP is a very basic thing, and it is a part of our trainings during the postgraduate. Still, why we are required to have a training, to have a discussion by such a senior person. So as madam has told that still we have 8% maternal mortality due to abortion related causes, though MTP Act in 1971 has a provision for prevention of unsafe abortion, but still we couldn't that. So this is the slide what I always want to share, that is the WHO motto: how to prevent unsafe abortion through comprehensive sexuality education, affordable contraception and safe abortion care. So part of safe abortion care we will discuss in next this, and this slide what I want to convey, that is the message of WHO Geneva, that regarding safe abortion, that not only that we have some protocols and some treatment part and the women they will choose this. No, we have to respect for women's informed and voluntary decision making autonomy. That is very important, that you have to take informed consent, you have to give proper counseling, confidentiality, and this confidentiality part is kept very precisely in the MTP Act amendment, as well as privacy with attention to adolescent and women with special needs. So today we are going to have a discussion with the high-risk women, and this is the all activities with all of your societies, that MTP should be continued with provision of saving the girl child. We all have done together, and this comprehensive abortion care is the we have to accept in our protocol. Without this, we can't give abortion related care. This is only the things, and as when we give to the cases, this is the thing which applies to all cases, that how one must approach for the case of MTP. So once a woman comes for the MTP, first you have to confirm the pregnancy, then you have to confirm the gestation, then identify indication of MTP, that is in the MTP Act, and then discuss the different methods of MTPs, medical or surgical. Then provide the counseling for the contraception. This is very much emphasized, that in the first visit when you are doing the counseling for the methods of termination of pregnancy, you have to at the same time counseling for the contraception. And when this is all done, then you have to obtain the informed consent of women and guardian to the Form C. That is the document, and then complete the Form 1, and then you have to provide MTP services. So please remember that the Form C and Form 1, that has to be filled before the procedure, and then you have to keep these forms in the safe custody and give the serial number to these forms. Not the patient's identity has to be confidential. And this complete the Form 3. This in the end I will give you all these forms, and then only the CMO they can see these forms. And in the last, all medical methods of abortion, you have to fulfill all these forms. So with this, I go to the first case, and we have a very good panelist. So Madam Dr. Asha Mishra, Madam is here. She is a very senior obstetrician. Madam, that it is said that MTP in high-risk cases. So what are the high-risk cases we are talking about, and how these high-risk cases should be identified? Madam.
Good evening, everybody. And first of all, I congratulate everybody for making this topic and keeping this webinar just post-Holi. Happy everybody, belated Holi and Women's Day. And I thank organizer for making me part of this important, prestigious, important. So as we know, all the MTPs can be at risk, but various health issues which if incorporated during the MTP can pose the MTP into a high risk cases. Now risk can be we can enumerate from the age, the age below 18 years, of course, can turn into a high risk case. Same way is the age above 35. Nulliparous women, that means the parity is also an important issue. There could be lifestyle issues also. Obesity. As the obesity increases more than 30, the comorbidity also increases. Now, various pre-existing medical diseases for which the MTP is usually opted can also pose the MTP into high risk. And we can categorize them according to the organ size. Like suppose cardiac diseases like coronary artery diseases, cardiomyopathy, history of peripartum cardiomyopathy, pulmonary hypertension, moderate to severe left ventricular outflow obstruction, ventricular tachyarrhythmias. If we see the respiratory illnesses, uncontrolled bronchial asthma, restrictive lung disease, pulmonary hypertension. Hypertensive disorders can be uncontrolled high blood pressure, that is more than 160 to 105 degree, that is diastolic. Kidney disease, CKD, where the creatinine is more than 2.5. Also the pregnancy termination in cases of renal transplant. Liver diseases could be wherever the enzymes are elevated. Esophageal varicosity with history of bleeding disorder, and uncontrolled inflammatory bowel diseases. Hematological disorders can be severe anemia, sickle cell disease with crisis, idiopathic thrombocytopenic purpura, history of previous DVT or PE, von Willebrand's disease, thrombophilias requiring anticoagulant therapy. Certain endocrinal disorders which should be looked for, and those are very common: uncontrolled diabetes mellitus, uncontrolled hyperthyroidism, pheochromocytoma. CNS disease could be epilepsy, space-occupying lesion, various vascular aneurysm if they were untreated. Besides this, when we come to the obstetric problems, the previous obstetric surgeries, the commonest we are having is the cesarean section. That is a scarred uterus of 1, 2, or 4 cesareans. Surgery done on the uterus, such as myomectomy for the scar dehiscence in previous surgery, Mullerian anomalies, bicornuate uterus or uterus diastasis with pregnancy in one of the horn can be also a risk. Severe psychiatric disorders and pelvic tumors, if they are associated, all can be the high risk. Yes, please.
So, madam, you have elaborated all these things. The issue is how they have to identify. So, what you have to do, we all know that it is then as the patient comes, comprehensive abortion care, you have to do the proper clinical assessment, and you have to take detailed history, not only for these, as madam has said.
Yes. Yes. So identification of risk. The key of the assessment, the key of identification is a thorough history and meticulous examination. And this can detect the majority of pre-existing problems. And if we find out there's certain kind of problem is there, then we can take the opinion of a specialist depending upon the previous medical problem. So a detailed history of the problems, a detailed history of menstrual history pertaining to the LMP to confirm the pregnancy, to confirm the duration of pregnancy, a personal history for tobacco, diabetes, drug intake, medications, allergy is also important. If there is a pre-existing medical illness, inquiry should be made about diabetes, tuberculosis, hypertension, bronchial asthma, renal disease, epilepsy, autoimmune disease, bleeding diastasis, DVT, or cardiac problem. That means we have to put the leading question. If the patient says the patient has suffered in the past from certain very kind of the symptoms suggestive of various these diseases. And we should also take the obstetric history in detail, where was there any surgery done? If there was a cesarean section done, when was the last cesarean section done? How many cesareans have been done? If there was a myomectomy done, what time the myomectomy was done? How long was the myomectomy? Was there any history suggestive of any Mullerian anomalies? That means she might say repeated abortion, or she got a history of any unification. That means history gives clue to the various risk problem. So history is the integral part of the identification.
So basically, because what you have told that such a detailed history, so one has to train their subordinate staff or their sisters or their junior doctors, and they must make a checklist for their.
Sure. That's very good idea. If we make a checklist, we can will not omit any of the problem.
Yes, and second thing is that nowadays it is said that history of observation for sexual or domestic violence also be asked at the same time, and other thing that history of taking the any misoprostol or any attempt for termination of pregnancy by self also taken care of. So MTP is always not a simple thing. One has to rule out all high risk factors and then they should start the process. But in cases of medical disorders, MTP should be done always at tertiary center and supervision of medical expert, as madam has already told. Now, what is the role of ultrasound for? Of course, I think not need to go in detail.
Excuse me, before ultrasound, the physical examination is also an integral part. That can detect a lot of problem. That means the general examination, everybody knows. Systemic examination should only be done to a particular organ system where we find there could be abnormalities. Abdominal pelvic examination to confirm. And basic investigations which should be done, I think need not to be narrated. Beside the basic investigation, LFT, KFT can be done in certain very cases. Now, when ultrasound should be done? Ultrasound is not a mandatory procedure, but it should be always be done in a scarred uterus in case of cesarean section to rule out the placenta accreta and scarred ectopic pregnancy. Also, in cases of pregnancy with Mullerian anomalies, it can also be done in cases of unmarried girls when they are hesitant to go for any internal examination, and also can be done to assess the gestational age where the clinically you are not able to do. Ultrasound can also be used to guide certain termination procedures also.
So this is important that because in MTP I tell that ultrasound is not mandatory, but we have to taken care of to rule out, and in special cases definitely it should be used, and the laboratory investigations, though in MTP only basic investigations are required, but whenever you are having the suspicion of some systemic disease, definitely you have to go. So thank you, Madam Dr. Aisha Mishra, Madam, that everyone giving the message that how thoroughly clinical examination should be done before any MTP. And once it is in reflexes, it take very less time, though in speaking and in the giving verbally is a long list, but definitely. Now come to the next very important question. Dr. Anupam Futela is here. That madam, there is a 37-year-old woman. She is unmarried and she is nullicabrida, BMI 35, obese, moderate anemia. She is willing for termination of pregnancy of 10 weeks. So what are the different issues we have to handle? What should be approach and method? Madam, Dr. Anupam.
Thank you, Dr. Bharti, for that question. And before that, good evening, everyone. And special thank you to the PSC committee, Dr. Monica, Dr. Shatabdi, Dr. Priyankur, and Dr. Vidhu and Dr. Bharti to invite me here and participate here. Well, Dr. Bharti, the case scenario which you had given me, in this patient, I can see that she's a 37-year-old female, which is an elderly patient. Second, I can see that she's unmarried, nulliparous, so the cervix should be tough to handle. Third is her BMI is 35, so she looks that she's obese also. And moderate anemia is also there. And also the pregnancy size is more than 9 weeks. It is 10 weeks size. So there are so many things to be tackled in this patient. And first of all, before moving ahead, I would first want to talk, basically, at heart, I am an infertility specialist. So the first thing I will let her know that this is her biological clock is ticking and she really wants to take this decision of MTP or not, she has to reconsider. Now, I am assuming that she has to terminate the pregnancy. Now, after that, if she has to terminate, rather than going for medical means in this patient, I would rather go for a surgical way because she's already anemic and I do not want to prolong her time of bleeding. And for that, I would want to go for a surgical option. And before going for surgical option, since the cervical dilatation is to be done and it's a 10 weeks pregnant patient, I would prefer to do, see, the cervix can be ripened two ways, a slow, rapid dilatation could also be done and a slow dilatation could also be done. And the slower dilatation are more preferred because the tissues are expected to be tough in a elderly female. So I would rather go for a meso insertion a night before and then, or early in the morning, and then do her surgical evacuation. And surgical evacuation can be done by two ways, the manual vacuum extractor or the electrical vacuum extractor. They are the two ways which are commonly done.
So very beautifully, Dr. Anupam, you have handled all these issues, and you covered all these things. So here I would want to emphasize that in such a cases, whenever you have so many issues and the woman is like that, the counseling is a very important part. It is always said it is not only minimize the litigation, but make good rapport with doctor and help women for better compliance of treatment. And so it is very important, and should do counseling. It is important that trained counselor either you have or doctor and paramedic staff. If there is a high risk pregnancy, they should talk to the patient for a few minutes so that you can convince the high risk factors to the women. And beside that, the always pre-procedure MTP counseling is help to choose the method. You have said to decide determination of pregnancy, consent for the procedure, and adopt a contraceptive method. This is a very important part. And the counseling for the contraceptive has to be done at the same time and help the woman to sign the consent. As well as there is a very important slide where here it is told that woman should be assured that she will not be refused MTP even if she doesn't accept any contraceptive method, and you continue to do her service, because otherwise she will go for the unsafe abortion, and counsel her again and record the all assessment finding, procedure, contraception refusal to accept contraception advice given. All these things I am telling you about the comprehensive abortion care by Government of India. And this is the one slide that information to a woman who is being referred to a high level. So what formalities you have to done, explain the woman, spouse or relative accompanying the person if you don't have a facility at your center, region why she is being referred, explain which facility she is going, give a referral letter with detail of history, examination, treatment, facility, transport to the next level of facility. Emergency transport facility can be used for referral if required. Contact the provider at the referral site if possible, giving information of the referral. Instruct the woman to report for a follow-up either at referral site or facility from where she has been referred. Record the referral. Plan to follow up later. Woman, even she is referred to other site and she is taking treatment, please follow up. And during follow-up visit, also always try the patient for the contraception counseling as well as follow-up. So this was about the case. What has it? Dr. Vivu, you will take this case.
Yeah. So, Dr. Rima.
Good evening.
Good evening. So, she's a 28-year-old woman, G3 para 2 with 8 weeks of pregnancy with heart disease. Once termination due to contraception failure methods. So, how do we proceed for this case?
Good evening, everyone. And I would like to thank all the organizers for giving me this opportunity to talk about a topic which is really very relevant in a country like India, where the population is growing like it's just like a bomb explosion. So we really need to work very hard on these things.
Absolutely.
And yes, heart disease is something which we are really bothered in places, especially in America, working in a medical college, a tertiary institute, we get a lot of patients like this. So one thing I want to say is that most important is first that whatever heart disease is there, it should always be referred to a tertiary center. No district hospital or sub-district, any hospital should attempt where facilities for intensive care units are not available. Like in my state, only in our hospital we have ICUs. In all the other districts where we have medical colleges, but we do not have ICUs. So we do not recommend that they should be doing this kind of MTPs, even if it's a mild kind of heart disease. So definitely once you have a patient, you have to categorize what kind of heart disease it is, whether congenital or coronary or cardiomyopathy. And in India, we still get a lot of rheumatic heart disease. We should not forget, we do get, and mitral stenosis, regurgitation, and all those lesions we do get. So first is we have to evaluate the cardiac status, and then we need to refer the patient to a cardiologist so that he can exactly evaluate and let us know what amount of the cardiac function is there. Like we are doing the echo and all, and we are seeing the ejection systolic fraction, and we keep a cutoff 40, 50. Beyond 40 is very dangerous. So after 60, somehow we feel is relatively safer. So first is the evaluation by the cardiologist. And then secondly, the counseling is very important. Patient has to be told that she has completed a family, she has 2 children, and now she has to take a decision that not only for termination, but even then she has to adopt a way that she doesn't become pregnant time and again and she keeps coming. So these type of things. So once everything's decided, investigations, and since she's a high-risk pregnancy, I would definitely like to do an ultrasound before I proceed, because maybe there can be some other pathology correlating and we are beforehand prepared for it. So those would be my options. And then we have 2 methods we already know. We have the medical methods and the surgical methods, and medical would be the mifepristone day 1 and misoprostol day 3 like we give. But personally, I feel that because these drugs do have some side effects in cardiac patients, like misoprostol can cause cardiovascular events and myocardial infarction, angina, all these things. So personally, I would feel that surgical evacuation would be safer in this patient because she's 8 weeks pregnant, and medical evacuation is usually till 7 weeks it's good enough. And if we use a high dose of misoprostol, which is required for first trimester, usually 400, 600, and that can have a problem in the patient. And small dose will not do. And second problem with the medical this evacuation would be that usually patients keep bleeding for sometimes 1 or 2 weeks. So usually it takes time. Sometimes they may bleed till 14 days also. So that would just put her at a slightly higher risk for infections also, because she's bleeding, and sometimes then she may land in incomplete abortion. So she'll need an evacuation anyway. So I think it's a better option to do a surgical evacuation under anesthesia. She's evaluated by the anesthetist, and either by a sedation or whatever the anesthetist feels is a safer anesthetist, you can do one-time evacuation, and after that you can counsel her. And personally, again, I feel that permanent method of this would be better for her, and especially if the husband would agree for vasectomy, that would be the best. So I think that would be the
thank you. That's absolutely right. We need to counsel, we need to take care where we are doing this kind of abortion, and we need to tell the patient all the problems involved with the cardiac status of the patient before taking her appointment. Would you like to give her a cover up with her antibiotic?
Yeah. We in our setup we are doing. Though the literature says that nowadays we don't need to give infective endocarditis prophylaxis until and unless it is some complicated or there evidence of infection. But in our government setups and the kind of patients we get, we do give them endocarditis prophylaxis, and then we continue till 5 days. That 2 gram ampicillin or the ceftriaxone 1 gram we give with Genta just before 1 or 2 hours before the procedure, continue for 24 hours, and then after we shift them to oral antibiotic and give them for 5 days. So that
what kind of contraception would you advise her later on?
Personally, I said I would ask her to get a permanent contraception, because for cardiac patients, nothing is very safe. Relatively, ICDs would be safer, but still we have the risk of infection. So, and she's completed a family also. I think a permanent method would be a better option. If the husband would agree, vasectomy, and if he doesn't agree and they want a permanent, then she can go for a ligation, abdominal ligation, because lapro again would be slightly risk for her cardiac status.
So safety first, so that we give the best to our patients.
But under cardiologist and expert anesthetists in the tertiary center, most of the patients I think are able to manage.
Absolutely. Thank you. Anything else, Dr. Bharti, you want to add? You're on mute.
Basically, very beautifully covered, Dr. Ima, all things, and basically the message you have given that in cases of cardiac disease, first thing physicians or cardiologists, this opinion should be there. And second thing, you have said that it is very clear that definitely misoprostol in the large amount or in the large dose, it is a controversial. Many studies has to be done where the large dose in the vaginal and they causes the cardiac problems. So, and especially in the cases where she is a smoker and obese and other high risk factors. So better that in this particular case, surgical evacuation is the best. And once you are using the oxytocin and also methylergometrin or prostaglandin up to help, so you must remember that they are the vasoconstrictive actions, so may lead to sudden severe hypertension, so you have to remain conscious. And pulmonary edema can occur in the intravenous infusion of oxytocin. So these all things can aggravate the heart disease, so it must be remain, and counseling is very important. All anesthesia risk and other things has to be explained to the woman and has to be done definitely at the tertiary centers, and proper follow-up. And regarding contraceptions, of course, permanent is the best if it can be done. Otherwise, COCs, they should be preferably avoided, and all other contraception can be used. And infection prevention is the important thing. One has to be taken care of in cases of cardiac disease. So, thank you, madam. And now come to the next question to Dr. Ritika Agarwal. Ritika, one woman, she is a 29-year-old with multigravida with 14-week pregnancy. With hypertension and congenital anomalies, she comes to you for the termination of pregnancy for congenital anomalies. So what would be your approach and how you will manage this patient?
Thank you, ma'am, for the question, and very belated Happy Women's Day and Happy Holi to all of you. First of all, my work has been made a little easy because she has come with her ultrasound, so the congenital anomalies and the site of the pregnancy has been confirmed. Secondly, since she is she's 14 weeks with hypertension, first of all, I'll have to see how much hypertension she has. So if she is severely hypertensive, her systolic and diastolic BP is more than 160 and 105, I would counsel her it will be better for her to go to a tertiary care center, since I'm working in a secondary health setup. And then next thing is counseling of the patient and investigations. What is her blood group? What is her hemoglobin? Her RFT, her coagulation profile, everything. Then I'll go for a physical examination. How much that is, since she is multigravida, mostly her cervix is very reactive, and she'll be very reactive. And I think this is the first case in the entire presentation which I'll go for a medical termination rather than a surgical procedure for her. So Mifi-Meso will be given to her. And then the only thing we have to make sure and we have to keep in mind is that after the procedure, the ergot derivative should not be given since she is hypertensive, and we should manage her with oxytocin preferably.
So Ritika, very beautifully you have described all things. In such cases, whenever you have some case of MTP, so always you have to keep in mind 2 or 3 things. First thing, whether you are eligible to do MTP, number 1. Number 2, you have to see then other documentations and methods. So like congenital anomalies, in all cases of congenital anomalies, they are not allowed for the MTP, those who are the life threatened. So always here in such cases, sometimes you do and patients come after that, then they have litigation that my baby could be survived and you have done MTP. And sometimes if you don't do, then they want that it should be done. So ideally always some fetal medicine expert or some person, the expert that these babies should be terminated, and it such type of things, the documentation should be there. Counseling is always good, and hypertension and 14 weeks. So cervical preparation, always 14 weeks is the important issue. So we all know how to do it. And hypertension, so whenever woman is having the hypertension, other system has to be done. Definitely termination has to be done at the higher centers, and at God's drugs, they should be avoided. Oxytocin, misoprostol, they are acceptable uterotonic agent. And oxytocin, and in such cases, sometimes hypertension, they have a chances of excessive bleeding. So you must remain prepared to handle such cases. So thank you, Ritika. Now, Dr. Vidhu, you will take this case.
Yeah. So Dr. Chanchal, this lady is 34 years old woman with 20 weeks of pregnancy with diabetes with congenital anomalies, willing for termination. And so kindly let's discuss the approach and management for this patient. She's a diabetic, she's 34.
Thank you, Dr. Vidhu and Dr. Bharti, for moderating the panel and involving me. And I thank the organizers to involve me in this panel. Now, coming to the case, she is a 34 years with 20 weeks of pregnancy with diabetes and congenital anomalies. So first of all, before proceeding to terminate her, I would like to emphasize on the congenital anomalies. You know, it's almost 1/3 of the MTPs in a tertiary care center these days are because of the congenital anomalies. So what is lacking is, I would like to emphasize on preconceptional counseling, especially in patients with high risk, like this is a patient with diabetes. If she is a pre-gestational diabetes, so preconceptional counseling is a must, which plays an important role. The role of folic acid, the control of diabetes in this patient should have been done. And I request my physician friends and the endocrinologist, they should put a word to these patients, because they don't come to us. They go to them for their diabetes control. So they should put a word to them that before getting pregnant, they should get their HbA1c levels. They should consult a gynecologist whether she can conceive or not, so that these anomalies can be prevented. Now she's 20 weeks and pregnancy needs to be terminated. Second point I would emphasize is on, as per the new Amendment Act, this is 20 weeks termination can be done by a single practitioner. We don't need to have 2 practitioners for opinion and terminating this pregnancy. Now the methods, coming to the methods for termination, I would like to use the medical method, that is with the mifepristone and the misoprostol. Again, by 200 milligrams of mifepristone on day 1, followed by 24 to 36 hours of 400 or 800 micrograms of misoprostol every 3 hours, maximum to 5 doses of misoprostol. And it really works well. Though other methods are available, which have gradually become obsolete, like Emcridil and using a Foley's as a mechanical method for such terminations. Third thing, regarding the diabetes status in this patient, I would as such, we don't need to change any doses of the oral hypoglycemics or the insulin if she is on. But definitely we need to monitor her sugar levels during the termination, during the induction of abortion when she is in the process.
So Ritika, you have told, very such patients, they are more prone to hypoglycemia in the first trimester. So sometimes dose has to be reduced, especially if you are doing some pre-procedure fasting or deep sedation. And beside that, schedule first or as an early case in the day, and post-procedure medication requirement may decrease. And of definitely help for the medical provider is recommended. Post-abortion contraception, all options are open for that woman. So all things are covered. I think we should go to the next question. So, Dr. Vidhu, you want to say something about this diabetes case?
I would just like to suggest, yes, absolutely this should be done in a tertiary center, because diabetes itself can pose a lot of problems in case it is not controlled. So we should have a backup for this lady.
Okay, so now next question, 28 years old with 8-week pregnancy with asthma. Very common situations, women have this complaint and they come for the termination. So Dr. Alka Yadav, madam, what things you will take in care and how you will counsel and what method you will use?
Good evening, everybody, and a very happy Women's Day. And I also want to thank the organizers for making me a part of this forum and for such an important topic. First of all, in this asthmatic women, I'd like to know whether she is primigravida or whatever her history is. Why does she want to go for the termination? Because asthma, although it is very common disease during pregnancy, but all the asthmatics do not need abortions. So if she really wants to go for the abortion, so we have to consider her the obstetric history also. Then 8 weeks is a very convenient time for abortion. So considering her status, we will see whether she wants, we can go for surgical abortion or medical abortion. But for surgical abortion, we will have to be having a very safe anesthetic for her, because all the drugs cannot be used for surgical abortion. Either we use a local anesthetic with mild sedation of midazolam, and if needed, we can use ketamine also. And for the medical abortion, we cannot use mifepristone, because mifepristone will cause more of bronchoconstriction in these patients. So we'll go only for the misoprostol doses for terminating this pregnancy. And later on, we can advise her for the counseling for contraception. So for that, we will advise her only for the oral progesterones or oral pills, because they are more safe in the bronchial asthma patients. Being steroids in nature, they will control the bleeding also and help her later on also.
So, like you very beautifully, you told all these things. So, basically, women with history of asthma without current symptoms, they undergo usual care. Definitely, in this, some indication of MTP is not mentioned. It's not because of asthma she is going for MTP. And then, of course, if well controlled, she can continue to use that medication what she is using for the asthma, and prophylactic use of inhaler with nebulized albuterol before the procedure may be prudent, and F2-alpha is not recommended, misoprostol is not contraindicated, and the hospital setting is recommended, and post-abortion contraception has to be taken care. So PG,
I would just say, as a painkiller, we should avoid ibuprofen and diclofenac in asthmatic patients. Paracetamol is a drug of choice in these patients, but as a pain.
An analog should be used in case of post-abortal atony, excessive bleeding or cervical ripening. Misoprostol is safe, and women should be stable and not have an acute asthmatic attack prior to the procedure. So now Dr. Namrata, is Dr. Vidhu, next question.
Yeah, 30 years old woman with 10 weeks of pregnancy with thyroid disorder, willing for termination of management. So Dr.
Thank
Namrata.
you. Yes, ma'am. Good evening, everybody. Thank you, Public Awareness Committee. Thank you, Bharti ma'am, Dr. Vidhu ma'am. One thing that I would like to highlight here is a lot of patients in our practice have subclinical hypothyroidism, and generally we do not take it into account when we are performing an MTP. Now, this is a woman who has a 10 weeks pregnancy, so medical abortion, method of abortion is out. We need to do a surgical evacuation. Having said that, I would like to grade these thyroid disorders in a hypothyroid patient first. In a mild to moderate hypothyroidism, we can go ahead with a surgical abortion. If the patient is already taking her thyroid medicines, she has to take it on the day of the procedure as well. However, certain precautions have to be taken when we are performing these surgical abortions. Number one, in the pre-op period, there need to be a caution for airway, because these are the patients who may be obese. These are the patients who may have short necks or thick tongues. So airway maintenance has to be cautiously dealt with. These are the patients who are more prone to drug-induced respiratory depression, especially with narcotics and opioids. So these patients need to have a ketamine. The ketamine need to be used during her procedure, and an aspiration prophylaxis in these patients is necessary, because we tend to forget that these hypothyroid patients have delayed gastric emptying time. So, but however, in the post-op, again, as Dr. Vidhu was pointing out, especially in thyroid patients, narcotics and opioids should be avoided. In a severe case of hypothyroidism, try and delay the procedure by a few days, start her on antithyroid drugs, and then we can start. And a medical emergency in cases of severe uncompensated hypothyroidism in the form of myxedema, coma is known, which has a very high mortality. And therefore, if we are performing a medical surgical evacuation in a patient with severe hypothyroidism, we should take care. What is important in these patients to know is, in severe cases of hyperthyroidism, we have a medical emergency called thyroid storm. So generally speaking, severe cases of hyperthyroidism should not be taken up for surgical procedures, and the evacuation should be delayed by 3 to 6 weeks. However, IV thyroxine and IV anti-thyroid drugs can be taken. Important point to note in these patients of hyperthyroidism, in these cases, avoid ketamine, avoid atropine, avoid percurium, all those drugs which lead to a tachycardia. So in these cases, thiopentone is the drug of choice. And of course, always perform in a tertiary care center. Anesthesiologist has to be taken into account. And as far as post-abortion contraception is concerned, there doesn't seem to be much of a contraindication in using any kind of contraception.
Thank you.
Basically, yeah. Dr. Bharti, please continue.
So I think all panelists, they are so good orators and they are so learned. They are covering all things in very less time. So now come to the last question, and I am very happy that such a vague panel is going to be ended. So Dr. Sangeeta Agarwal, madam, that is a very interesting question. Many of us wanted to know that unmarried girl, 17 years old, Nali Gravida, came with patient parents for 10-week termination of pregnancy. What are the legal and issues and clinical method? Here, I just want to emphasize, in the first question, we have taken the unmarried woman, but she was 37 years old. So I just want to tell you that any adult woman, either she is married or unmarried, she has the indication for MTP if she is having the contraception failure.
Yes.
And this is unmarried, so how, and it is a 17-year.
Yes.
So how it has to be handled, Dr.
So, good evening. And thank you to the organizers. So she is 17-year-old adolescent girl. She has come for MTP at 10 weeks of pregnancy. So she has not attained the legal maturity. So consent has to be taken by the guardians. She has come with the parents, so consent will be taken by the parents. And second issue is she has come under the FOGSI Act. So we have to inform the police before starting with the procedure. Thirdly, she is adolescent. She has to be dealt with empathy and care. So that is also important at this tender age. So now regarding the clinical method for termination at this gestation of 10 weeks, both medical and surgical methods can be considered. So the success of medical methods at 10 weeks is a little less. So the patient is counseled for the option of termination, about the procedure, the risks, and the complications and follow-ups. In surgical methods, what is important is this is a nulli gravida cervix. So there are two methods, rapid dilatation and slow dilatation. In rapid dilatation, we are, as you know, we are using serial metal dilators. So there can be injury to the cervix. There can be incompetent os later on. There can be injury to the uterus. So we should go for slow dilatation. That is before taking up for vacuum aspiration. That is the procedure. We should use either the laminaria tent or we should give misoprostol 6 to 8 hours before the procedures in the early morning. So what is most important in this case is after termination, of course, the contraceptive counseling, as the previous speaker also emphasized, which is very important depending upon the sexual needs of the patient. So we must tell her that before next periods, there can be ovulation and there are chances of pregnancy. This should be emphasized. Even in 10 days, she can have ovulation.
So it is very clear that whenever any girl comes to you, you have to take her age proof that if it is less than 18, then definitely woman has to be informed to the police. It's not necessary that you are going to do FIR or you are not doing your treatment part. You can continue your treatment part, but you have to just send the information to the police. And second thing, consent of the guardian on the form C, and cervical preparation is most challenging thing in
yes.
So what madam has told, rapid method is not recommended most of the time. The chance of injury. So cervix preparation nowadays with misoprostol is a very good. So one can use our cervix prime. That is a very good medicine. So thank you, madam. And now
I would just like to add, because she is young, unmarried, 17 years old girl. So, you know, at this stage, we should also counsel for her to give her HPV vaccination. We can right now counsel her. This is the time we can counsel her. If she's not
we can take the opportunity. Yes.
Absolutely. Absolutely.
Yes. Yes.
So this was the thing, and now last question that we all know that many of us, they don't prefer to do MTP. Always they show ignorance in doing MTP because there are lots of litigations, lots of formalities, lots of paperwork. So I just wanted to say that litigation, how to avoid. The only answer is counseling, counseling, and counseling. And this is a really skill, but of course, senior person or doctors who is the owner, who is in charge, should do themselves for at least 2 minutes. Then documentation, this is not very difficult. I'm just showing in the next few slides. On this PowerPoint, whoever want to have it, you can ask me on the mail. I will post it. Improving skills, what we were talking about, we have improved, we were revising our skills and know about the act. We can't escape, or we can't say that innocence, or we are not knowing, or we are not aware about the MTP Act amendment or MTP Act. So this is a part of our practice. And documentation for MTP in few seconds. This is the form that is it has to be used after the medical method of abortion. Many of us, we don't use. This is the Government of India's released form, and this has all information. So this prevent you many litigation. Second thing, this is the form A. This is the form which you have to use when you apply for your center for the termination of pregnancy, and this has two category: one for the first trimester, second category for second trimester onwards. And in the second trimester onwards, you need OT facilities. That is the difference. Then this is the certificate which all of you, those who are doing the MTP, should be displayed at your center. So this is the form B, and I know that many of us, you have either in your files or either you don't have. If you don't have, you get it from your CMO. And if you are giving the medical method, you can do it from your OPD where center is not approved, but you can display the approved centers or authorities that you are affiliated with that approved center. This is the form. This is the form C. This is the consent form. All MTP consent has to be taken on the form C. Besides that, you have to take care high risk consent on the other form. But this has to be used from the Form C. And this is the Form 1 opinion form. Before MTP, it has to be filled up. And this is the Form D. This is the new form after MTP Act amendment. And this has to be reported beyond 24 weeks. Whenever any girl or woman, they come for the after 24 weeks of termination. So this is the form where you can say that it has go to a board. And it comes the opinion of medical board for termination of pregnancy, whether it is allowed or denied. And this is another form, Form E. It is released after MTP Act amendment. It shows that 20 to 24 weeks. 20 to 24 weeks when you has to do MTP, there are certain indication. In this indication you can do, and you have to take signature of 2 RMPs when you are doing 20 to 24 weeks. So this form has to be filled. This is the Form E. So this was all about the safe abortion, Surakshit Garbhopat, Beti Bachao ke saath. We all have done lots of activities and now very much aware of MTP Act amendment, communication skills and documentation. And these all documents related to MTPs, they are available on the FOGSI website. This is the MTP FOGSI focus available on the FOGSI website. Those who want hard copy or soft copy, they can send request. And thank you very much. And I know most of you panelists, and I am happy that we are meeting again. We have met in many webinars in the past when I was MTP committee chairperson. So request all of you for the coming election year 2023 to support me for North Zone Vice President. And thank you very much, and thank you on behalf of we moderators, Dr. Vidhu and me, for this beautiful panel, and all esteemed panelists, organizers, and public awareness committee with North Zone 5, Dr. Priyankur and all. Thank you very much.
Let's all be safe and happy together.
I have one question, Dr. Bharti.
Yes.
Do we have this Form C consent is enough for the high-risk cases, or do we require additional consent?
No, madam, I have said already that this form has to be filled, but other consent you have to take separately for the high risk. This form is not sufficient. You have to, but you have to take one consent, and then high risk consent you have to take.
Thank you. Thank you.
Thank you, ma'am. Thank you, Vidhu, ma'am. Thank you for that excellent deliberation. We will move on to the panel. Okay, Richa ma'am, any comments do you have on that? Please, kindly, we would like to take your comments on the panel.
Shatabdi, Richa ma'am is not has not joined. She's traveling. She's in the flight.
Okay. So then, thank you all. Thank you for the excellent panel discussion. We will move on to the next panel. Our next panel is another very important, pertinent topic of today. It's cafeteria approach for contraception. We have our excellent moderators, Dr. Anita Sabharwal ma'am and Dr. Sonia Nayak ma'am. And once again, heartfelt thanks to Dr. Narendra Malhotra sir for agreeing to be the expert panelist for this at the very last moment. So our first moderator is Dr. Anita Sabharwal ma'am. Our dear Anita Sabharwal ma'am is the president of FOGSI. She's won many.
I will request Abdi to kindly cut short the introduction, and we'll go on straight with the comments of expert comments of Dr. Narendra Malhotra sir. So let's take the opportunity, and you can just go through the slide of my co-moderator also. And then
right, ma'am. Yeah. Right, ma'am. Thank you, ma'am. So welcome, Anita, ma'am. Welcome, Anita, ma'am. Our next moderator is Dr. Sonia Nayak, ma'am. Ma'am is the director and unit head of Max Super Speciality Hospital, Saket. She is the executive member of the endometriosis
and she's a good friend of mine. Enough. That's good enough introduction.
Okay, ma'am. Welcome, Sonia, ma'am.
Yeah.
Our expert panelist is Dr. Narendra Malhotra, sir. Sir is the managing director of the Global Rainbow Healthcare, director of ART Rainbow IVF.
Don't waste time reading this thing.
Yeah.
Don't waste time reading slides. Everyone knows.
Yes, sir. Yes, sir. Okay, welcome, sir. Welcome, sir. Can we have we have the expert panelist. Our first panelist is Dr. Shubha Pandey, ma'am. She is the head of obstetrics and gynecology at Kamla Nehru Memorial Hospital and the president of the Society of Prayagraj. Welcome, ma'am.
Yeah.
Our next panelist is Dr. Amrita Jaipuria, ma'am. Ma'am is the consultant gynecologist and obstetrician at Gorakhpur Hospital. Thanks. Yes, ma'am. Yes, ma'am. So next panelist is welcome, ma'am. Next panelist is Dr. Shweta Mathur, ma'am. Ma'am is a senior resident at
Thank you so
ESI
much.
Hospital,
Thank
Noida.
you.
Welcome, ma'am. Welcome, ma'am. She is a
Thank you
visiting
so much.
consultant at many hospitals. Our next panelist is Dr. Shalini Tandon, ma'am. Ma'am is the director of Tandon Multi-Speciality Hospital at Varanasi. Yeah. Welcome, ma'am. Our next panelist is Dr. Gitanjali Kaur. Ma'am is director and senior consultant of Pal Hospital, Ludhiana, and the organizing secretary of the North Zone Yuva FOGSI 2022. Welcome, Gitanjali, ma'am. Next, we have Dr. Sugandha Chopra. Ma'am is a consultant obstetrician and gynecologist at Lumba Hospital and IVF Center at Ambala Cantonment, and the joint secretary of the Society of Obs and Gynae of Ambala. Welcome, ma'am. Yeah. And our next panelist, we have the Professor Dr. Seema Hakim. Ma'am is a senior consultant at the Department of Obstetrics and Gynecology at JN Medical College, Aligarh. She has multiple achievements to her credit. Welcome, ma'am.
Thank you. Thank you so much, Dr.
Yes.
Stabdi, for the
Over
kind
to you,
introduction.
ma'am. Over to you, Anita,
Yeah.
ma'am, and Sonia, ma'am.
So I think it's a great introduction of all the panelists and the moderators, and especially our only man here and man of substance, Dr. Narendra Malhotra, sir, who's the expert here. And since contraception is a very, very important subject, as we've already seen in our previous lecture as well as the panel discussion, because that's the culprit. If contraception reaches the public, we will have all these problems. So for that, I think before we go on, I will request Dr. Narendra Malhotra, sir, to just.
Ma'am, you're muted.
Ma'am, you're mute.
Because
Anita,
sir
ma'am.
has to go somewhere and he's short of time, so we don't want to miss his expert comments. So before we go on with the panel discussion, I shall request sir, please say a few words on
So
contraception.
very good evening to all of you. It's indeed a pleasure to be here as an expert. I will try to be joined in. So maybe I'll be in the car when by the time it ends, because I've just finished OPD and I'm just going to get dressed. Have to go. Anyway, contraception is the only way today we can reduce maternal mortality to levels of SDG, what we want to have. See, we have done emergency obstetric care, we've done the home hospital institutional delivery. Our maternal mortality is below 100 now, which is a great achievement in the last 10 years. But we have failed to achieve contraception despite of so much of government money being pumped in. You can see advertisements of condoms, you can see advertisement of tablets everywhere. But yet contraception is not accepted. And it is again not accepted because of the education and empowerment. So women empowerment is very important. Pill is the most important invention which occurred in this century. A tablet can give the woman, makes her empowered to control her own fertility. But she has to go out and buy the tablet. And that is where the problem is. The husband is not willing to buy it for her. So many times she has to ask the father-in-law, brothers, devar, all that. And it makes, this is a truth in the villages. Let's not talk about even for sanitary pads, for tablets, condoms, they have to buy. So contraception, we just need to address contraception again and again. There is no new contraception coming on the horizon because it's too expensive to do. We have all the best of contraception. The lowest dose pills are there. The IUCDs are there. The rings are there. The patches are there. Everything, the whole cafeteria is there. But then when you put the cafeteria in front of a woman, you choose what you want. Now that is again where she gets confused. Arey doctor, aap hi bata do, aap bhagwan ho. So again, we need to, you cannot offer a cafeteria approach. Ye rahe 10 cheezein, samosa, idli, ye padi, jo khana hai kha lo. So that is not the way. We again have to individualize and guide these Indian women through contraception. So I believe, yes, tell her ki itne sare contraceptive methods hain, but this and this suits best for you. And involve the man, involve the husbands. That is what my opening remarks are. And if I'm there with you after the panelists, I will give the closing remarks also.
Thank you. Thank you, Malhotra, sir.
Thank you. Can I share the slides, please?
Yeah. Yes. Dr. Sonia Naik, please go on. my worthy co-moderator. She's going to take us through the slides. And soon we shall have very interesting and very simplified panel discussion.
Thank you, organizers. I'm taking it over from Dr. Guleria at the last moment. She couldn't join us. But thank you for giving this opportunity on discussing on cafeteria approach for the contraception. So understanding that it's a cafeteria approach for contraception, we are going to discuss what is the cafeteria approach, what are the things available in the cafeteria to offer, and discuss the very, very basics about these methods of contraception, as it's a public awareness committee rather than going to the depths. So we'll not be covering too much in detail about the medical eligibility criteria, but we're just going to discuss mainly the cafeteria approach. So in order to discuss only the methods available and discuss about those methods available. So as has already been told about the expert discussers and the expert Dr. Narendra Malhotra, we have already heard his comments. Now, talking about the contraceptive worldwide, over here we see that about 842 million, that means around 44% are using the modern methods. 42% are actually those people who are not in need, and 10% the unmet need. So you'll be we always talk about unmet need, we always talk about the words family planning, the contraception, but have we actually thought about what is the difference between contraception, family planning? We just discuss so much in everyday now OPD practice about the unmet need and all. But yes, we'll be talking about in a subsequent slide. And therefore, these things will become much more clear about these. And now talking about the percentage use of different methods of the contraception, the cafeteria methods, what are the methods available in the cafeteria? Talking about our own country. So there's 42% approximately women who are using some sort of a contraception, 29% going for female sterilization, only 0.2% for male sterilization. So still a male-dominating country that we have. Still the patriarchal rule is quite prominent. Then pills is only 3% of the total methods of contraception that is being used. Injectable only 0.2%. Implants, still we are struggling to counsel the patients and actually convince them to use implants. Intrauterine device, again, only 1.2%. Barrier method is 4.3%. Rhythm method 1.6 and 2.9 is the withdrawal method. Now, I'm going to hand over now to Dr. Anita Sabarwal for the further discussion.
Thank you. Thank you, Dr. Sonia. और आज के पैनल डिस्कशन को हमें बहुत ही सिंपल वे में ही एड्रेस करना है, because ultimately we want कि all these contraceptive methods they reach the public in a very, very simple manner. So we're all going to talk in simple language and the basics. So I start with the first question with our very able Dr. Gitanjali. So Dr. Gitanjali, are you there? I would.
Good evening. Yeah, I'm there. Yeah, good evening.
So I'm very happy she's from Ludhiana, my town where I studied. Dr. Gitanjali, I would like you to be the show starter of the day, and please define what is contraception, what is family planning, and what is the unmet need. उसका मीनिंग जैसे जानते हैं, बट अच्छे से हमें बताओ, सो दैट हमारी पब्लिक को भी ये पता चले, बिकॉज वी डॉक्टर्स आर गोइंग टू गिव, आप जो बताएंगे वही वी विल गिव इट अक्रॉस.
Yeah, good evening, everyone, and thank you for the question. And I thank the organizers for including me in this panel, important panel. So contraception means the deliberate use of any artificial method or any technique so as to prevent conception by sexual intercourse. That is the simplest definition of contraception. Family planning means an individual or a couple, they adopt some methods so as to attain the number of children that they want, so as to have proper spacing between their children, and so as to limit their family. So any methods that they attain to achieve all this is what comes as family planning. And unmet need. Unmet need is those females who want to use some contraception, but for lack of motivation, for want, they are unable to access or are not using any contraception. Those are the unmet need, and it is that we have to tackle. Whenever we make a new contraceptive, we have just as postpartum IUCDs and post-abortal IUCDs, they are very well looking after the unmet need, because it is at that time that a woman has already given birth. It is at that time that she really needs spacing, that she doesn't want to be burdened with another childbirth. And that is the maximum unmet need in our whole society. It is at that time that the maximum contraception is needed. And it is at that time she's very receptive also to contraception. So that is what is an unmet need. It is the number of women who do want to move to some method of family planning, but are not using anything. And here we have to target these women. So that is what is unmet need.
Thank you. Thank you so much, Dr. Gitanjali. You have really told in a very nice manner what is contraception. So now I would like to go on with Dr. Shubha Pandey. Madam, I would like to ask you, what are the characteristics of an ideal contraceptive? Jo kitna badhiya ho that people would like to go for it. Yes.
Yes, thank you, Dr. Anita and Dr. Sonia, for inviting me. So what are the characteristics of an ideal contraceptive? That is our aim. So of course, it must be safe. It must be 100% effective. Ideally, there should be no or minimal side effects. There should not be any difficulty in obtaining it. It should be easily obtainable. The cost should be low. It must be affordable. Only then the people will be able to take it. And most important, it should be acceptable to the user. And of course, it must be free of effects on future pregnancies.
Very right. Very rightly you said. Ideally, it should be there, but usually we don't have all the characters in whatever contraceptives we have. So ultimately, we have to explain to them and counsel them. So now we go on to our next question to Dr. Sugandha. Dr. Sugandha, what are the benefits of contraception? Why people should opt for contraception? हम क्यों इतनी बात कर रहे हैं कि contraceptives का use ज़्यादा होना चाहिए? How does it help us? Dr. Sugandha, are you there? Is Dr. Sugandha there? So the various benefits of contraception, which I wanted to ask Dr. Sugandha, क्योंकि हम अभी सुबह से यही बात करते आ रहे हैं when we talked about post-abortal contraception, and then we were talking about this abortion. So it prevents a lot of disease and death in the woman, and it reduces the unsafe abortions from unintended pregnancies. Dr. Sugandha is there, and thus it reduces the newborn and infant mortality as well as morbidity. And also it prevents, certain contraceptives like condoms, whether male or female, they do help, though mostly male condoms, they help to prevent the HIV and AIDS also. And also, especially the adolescent pregnancies, they can be reduced. And thus, by doing all this, it empowers our people, enhances education, and contributes to the economic growth, and also well-being and autonomy of women is secured ultimately. So contraception is so good for the health and wealth of a country ultimately. So I think Dr. Sugandha was not here. Maybe next question she might be there. Maybe due to net reasons she was not here. So now I will ask Dr. Sonia ji, please go on with the next question. Dr. Sonia.
Yeah. Dr. Seema, the next question, that is what we actually came here to discuss about it. What is cafeteria approach? This is a title of, and this is the idea behind the entire panel. What actually means.
Good evening all. Thank you very much for that question. Though Dr. Narendra has already talked something about cafeteria approach, it is just like going to a cafeteria and ordering things. But the main difference with the cafeteria approach of family planning and going to a cafeteria is that nobody is going to tell you how it is going to taste and how it is going to affect you. So here in family planning, we have a basket of methods. And different methods will be discussed in due course of time, but to be short, there are some temporary and some permanent methods of contraception. Amongst the temporary method, barrier, hormonal contraception, there are a variety of contraception. So when we have a client for family planning services, we should make that client comfortable and explain to the client about the different methods of contraception and help them choose one method. As Naren said, that just tell them to take any method and start using it. It's not like that, because a method which is suitable for one group of person may not be suitable for other group of person, and we should keep everything in mind when we help them choose a method. So we just don't offer them things ki tum kuch bhi le lo, but we educate them first about the contraceptive method. And after educating that person, we help them which method is going to suit them. So that is about cafeteria method. And if we follow this method, then our family planning program will be really effective, because now the client, once they are educated and they know what are they going to use, it becomes very easy to offer themselves.
So, correct, Dr. Seema. So it's basically
मैं
depends
एक पॉइंट बोलूं डॉक्टर सोनिया, मेरे मन में आया कैफेटेरिया में कोई भी गया तो कोई भूखा नहीं गया, वो उसका पेट तो भर ही गया, चाहे उसने थोड़ा कुछ लिया या ज्यादा थाली ली या छोटी थाली ली. So ऐसे ही even in our this cafeteria of contraception, I think all women when they come, they shouldn't go back without any contraception. Whether they take a simple condom method, whether they take any fertility awareness method, or they take any IUCD method, or they go for permanent. So that is the idea, that cafeteria could fit in each and every book. Thanks for giving me the opportunity.
Yeah, so this is the take-home message of our panel discussion today, Dr. Anita. So, right, Dr. Seema said, it's basically depending on the family history, the medical history of the person, the examination findings, that we can offer them the choice and then discuss about that method and then help them choose the method. So, Dr. Shweta Mathur, we talk about this in the cafeteria method about the word gather, and can you just help us know what it means actually?
Thank you, ma'am, for the question. And basically, gather method is designed so that patient should not feel subdued. We should be friendly to the patient. We should make her comfortable, and she should feel that we are guiding her as we are in her situation. So first we greet, make her comfortable. We can even talk in her own language, and then we ask her, what is your contraceptive requirement? You want a short-term method? Are you going to plan a pregnancy within a year, or you want to wait for 3 to 4 years? So that we can make up our mind what method would be better for her, so that we can decide. We can also ask her about her bleeding, if it is heavy or light, so that the contraceptive she chooses will also make her comfortable in the problems which she is facing. Suppose she's having acne, we can choose a contraceptive pill accordingly. Or if she's having any repeated infections, so we can think what will be better. IUCD may not be good for her. Then we can after knowing her family planning goals, then we have to tell her what are her choices which are going to suit her in her condition. कि आपके लिए अगर मोस्टली पेशेंट्स कहते हैं कि हम कॉन्डम यूज कर लेंगे, बट जनरली कॉन्डम यूज करना उसके पार्टनर के ऊपर डिपेंडेंट होता है. तो उसको वी कैन आस्क कर कि भाई तुम अपने हस्बैंड को भी बुला लो, साथ बैठ के डिस्कस करने से it gives her more empowerment and she can take a decision which she can follow. And also with the condoms we can tell her कि इसका failure rate वगैरह क्या है, अलग अलग मेथड जो भी हम उसको सजेस्ट कर रहे हैं उसके बारे में हम उसे इन्फॉर्म करेंगे कि इसका फेलियर रेट कितना है. कि आप जैसे कॉन्डम यूज कर रहे हो तो इसका देखो 7% तो फेलियर रेट है ही, अगर आप ठीक से नहीं यूज करोगे, कभी कभी करोगे तो 14% भी हो सकता है. तो when we tell the figures, they can get more idea of what they are using and it can fail. Then after telling her, we can help her to choose accordingly, if she wants to, if she can afford buying pills every month, what type of commitment she will be fine with. If she wants to spend only one time, then IUCD or this kind of contraceptive may be better for her. If she's having infections of STI and all, then a barrier contraception will always be better for her. Then when she chooses this, yes, okay, I would like to go for pills, then we have to explain her in detail कि आपको इसको कैसे खाना है, अगर आपको कभी मिस हो गया टैबलेट तो क्या करना है, कभी एंटीबायोटिक खाओगे तो आपको कुछ बैकअप भी लेना पड़ेगा, लूज मोशन होगा तो बैकअप भी लेना पड़ेगा। तो हमें उसको बारे में पूरा उसको बताना पड़ेगा। और हमें कई बार पिल्स के साथ या मल्टीलोड वगैरह के साथ बहुत सारी मिथ्स एसोसिएटेड होती हैं कि पेशेंट कहता है गोली खाएंगे तो हमारा वेट बढ़ जाएगा, मल्टीलोड इधर उधर सरक जाती है, हम, है ना। तो वी हैव टू टेल हर कि जो किसी और के साथ हुआ वो जरूरी नहीं आपके साथ हो। उसके मन की मिथ्स जो भी हैं उनको हमें हटाना पड़ेगा और उसको डिटेल में बताना पड़ेगा। फिर हमें रिटर्न के लिए उसे बताना पड़ेगा कि अगर आपको कुछ भी दिक्कत है तो आप वापस आइए, आप चेंज करना चाहते हैं कॉन्ट्रासेप्टिव, इस पे आपको सूट नहीं कर रहा, हम वी कैन ऑफर यू अनदर थिंग। तो वी हैव टू वॉक हर थ्रू इट।
Right. Absolutely.
Right, Dr. Shweta, beautifully explained to how to zero down on the contraceptive method. Over to you, Dr. Anita.
Yeah. Thank you. बहुत ही अच्छा सा बताया गैदर के बारे में. And after that, now we go on to the different methods of contraception. As we all know, we have temporary methods, we have permanent methods. Then in temporary also, we have the barrier methods, the natural contraception, the IUDs, steroidal contraception. And in permanent, we have the female methods and male methods, so which we will go on. So sabse pehle now we will talk about the basic method, which I think we started talking about, or which came into play in the year 1855. So the barrier method, the first one. So I will like to ask Dr. Shalini Tandon, ma'am, please tell us about the barrier methods of contraception. What types they are and how good they are. How do they work? How effective they are? And what all precautions we should take?
Good evening, everyone. Thank you for giving me this opportunity. Barrier methods are the most commonly used methods in India. And these are the methods which prevent the sperms from entering the uterus after ejaculation, and thus they prevent fertilization. So barrier methods can be classified into two types, the physical or chemical methods. In physical, most commonly used are condoms, and we have both types, male condom and female condoms. Then there are diaphragms, which are Dutch caps, and cervical caps and vaginal rings. Among spermicides, they come in various forms, in foams, gels, creams, sponges, etc. So the failure rates of barrier methods are 5 to 7% if used correctly. And if they're not properly used, then the failure rate may extend up to 20 to 30%. So whenever a patient chooses, after we have offered her this cafeteria approach, and whenever the patient chooses a barrier method, then we have to very nicely explain her how to use it. And if the male partner is using condom, then they should use it properly. And they should always see that there is no leakage, and the condom should be intact whenever they are using. And it should not break, and it should never be reused. There should be only a one-time use with condom. And so is the case with female condoms. And female condoms, female has to be educated how to insert it into her vagina if she prefers to use it. And in cases of diaphragm and cervical cap also, we have to educate the female how to apply it and how to use it. And if she's using a diaphragm, then it should be inserted 30 minutes prior to intercourse, and it should be left there at least for 6 hours for the proper action to take place. And we should always warn her that she should never forget to remove the diaphragm or cervical cap if she's using after 6 to 7 hours. It should not be left for more than 24 hours, because then it can cause serious complications like toxic shock syndrome. And when barrier methods, physical ones they are combined with chemical ones like spermicidal jellies, their efficacy becomes more. They become more effective. So if both the partners are using, like we have got available in the market today, foam gels, which are spermicidal foams. And if the female is using them, we have to teach her how to use it to apply it. That is snugs the cervix. It closes the os, and so it does not allow the sperm to enter. So it acts like both barrier method also and as a spermicidal method also. So if the female is using today and the male partner is using condom, then the efficacy becomes high. It can extend up to 99%. So we can offer this to the patient and we can counsel them regarding this.
Thank you, ma'am. आपने बहुत अच्छे से समझाया. And these are very good method. At least कुछ ना use करने से तो अच्छा है कि we can use these methods. And because also it prevents STDs and HIV also. So double. So double protection है. So this method is really always required. Even if you're using other method, this can be again used topped on that. And also जैसे
Ma'am, you got muted. Dr. Neeta, mute.
Because that affects the efficacy of the condom. And also condom should be applied on the penis quite properly, because sometimes they're loose fitted. So then also there is leakage, as you already said. And also the condoms can be really taken from anywhere. People can, it's very easy to get them. I think even Asha Didis also now they go and give it to them at their place also. So condoms, really, if they're used properly, they can be effective in really preventing a lot of death and disease amongst the women. Thank you so much.
Can I add one thing about condom?
Yes, ma'am. Bolo.
Yeah. It should be properly stored at cool places. Like in villages, you know, they have hut. And what they do, mostly they will keep it on the roof part, somewhere hidden, and it is directly gets heated up. And once it is heated up, then it loses its efficacy and it breaks very easily. And the other thing is the oil, vegetable-based oil, they make the condom like oil, they make the condom very weak. So we should instruct them not to use this oil for lubrication. And another thing is, whenever we are giving them condom, we should tell them that they should be applied before they start with the sexual intercourse. Many people, they will wear it at a little later part when
ejaculation is about to happen.
They have gone. Right. And one more thing is that if it breaks, then what to do? They should be told that if it breaks, what are you going to do?
Absolutely. Right.
Yeah, ma'am, just want to add one more thing.
Moreover, the counseling has to be really done properly. Many times what happens, we presume that the patient knows what we are saying, we are about to say. Like we'll say, apply it. Apply where? You have to say that on the penis, on the organ of the male. Because recently what happened, one nurse was explaining that, apply on the thumb.
Has to be pinched so that air is not trapped.
The air parts that should be left open. Like for your TVS probes, you are applying the condoms. No? So that way we can explain on that also. But one of the patients, recently it happened, one nurse, she was explaining on the thumb that this is how you apply on the thumb and this is how the condom has to be put. She put everything. She showed that the air bubble part and how approximated. And after some time that lady came back and she told that I have become pregnant. You told me the way you told my husband did that only, and now tell me. So then it was told that her husband was putting it on the thumb only.
Yeah,
so
that's what happens.
Everything has to be very clearly and nicely explained. So thank you so much. And now we go on to the next question. That is, I will ask Dr. Gitanjali again. So that is very, very important, which is the intrauterine device. And I think most of our doctors have been using, even I also have used in the past, and it was quite a good thing for us. So I will now ask Dr. Gitanjali to tell us all about the intrauterine devices as part of contraception, a good contraceptive method, and what kind of contraceptive devices we have, these IUDs, how do we use them, and what are their good points and what are their bad points. Dr. Gitanjali.
Yeah, thank you, Dr. Anita, for the question.
Yeah.
So IUD, intrauterine devices have been in use since 1970. Initially, it was introduced in US as the coil, the Dalphon coil, which was introduced, but it went into disfavor immediately after a few years because a lot of pelvic inflammation started happening with it. So then the design was modified, and it was in 1980 that these loops, these newer copper tees were made. Initially, it was silver was added to it, and then copper was also added. It is in the arm. It is a T-shaped thing which has to reach till the fundus of the uterus, and the arms have been made in different shapes. We have the copper T multi-load, which has the arms which are protruding from outside, small spirals protruding from outside, so that it has better contact with the endometrium. We have the T-shaped ones, and we have the one which had the flanges can go up or the flanges can go down while we are inserting the copper T. But the basic mechanism in all of these copper T based devices is that it is acts as a contragestational, that it prevents the sperm and ovum fusion. That is how it acts. And that is why copper T also acts as an emergency contraceptive also, because it prevents the fertilization. One, it makes the endometrium, the environment of the endometrium, it causes inflammatory changes in the endometrial environment. The copper added also causes inflammatory changes, cytokine receptor kind of inflammation in the endometrium. It thickens the cervical mucus. And these are the ways that it stops the sperms, firstly from going up, and secondly, because of the presence there, the sperms do not go up, and the endometrium itself has changes like that it does not prevent implantation. And that is why copper T prevents safe even in ectopic pregnancy. So it prevents pregnancy both. It prevents pregnancy and ectopic pregnancy also, because it does not allow sperm-egg fusion. And we have the newer types, which are the progesterone-loaded IUDs, which will be talked about maybe later on.
Right,
so, and then comes the how long are they effective. We have the one that are available are the one that are available for 3 years. Then we have the 5 years, and the one 380A. Though the recommended is 10 years, but it can be even kept up to 12 years. So this is the time period for which we can keep this copper T. And copper T nowadays is even recommended in nulliparous women. Government of India also recommend that, and ectopic pregnancy also not a contraception, contraindication for this. Thirdly, unless the patient has active pelvic inflammation, any previous history, even if the patient has some infection or inflammation or cervicitis in the presence of copper T, we always should treat it and should not go towards removing it. Postpartum and post-abortive insertion of copper T is a very big program of government, and which has been very successful to look into the unmet need about which we talked about. And if we are offering it to as a postpartum contraception, immediately at the time of cesarean, a copper T can be inserted within 10 minutes of within 10 minutes of expulsion of the placenta. So here you take a copper T and hold the fundus of the uterus in your hand, so that it can help as a guide, and then place the copper T right at the fundus, because expulsion chances are very high whenever they're inserted either post cesarean or postpartum, so post normal delivery. So in all of these cases, always try to hold the fundus of the uterus so that you can guide the copper T well into its right place, and you can hold the copper T if you with a ovum forceps or a Kelly's forceps, and let it go inside. For a normal delivery, in case of a normal delivery, it can be inserted 48 hours after the normal delivery. That is better because it causes less chances of expulsion of copper T. At the time of cesarean, it can be inserted right at the same time, because the fundus can be easily palpated and it can be kept there. For post-abortal, if it is a first trimester abortion, if it is a surgical abortion, it can be kept at the same time or within first 10 days. If it is a medical abortion, then do wait for 15 days before keeping the copper T. If it is a second trimester abortion, again, you can wait, put it immediately or within 10 days of second trimester abortion. Otherwise, anytime within first periods, after periods is the best time. 5th, 6th day of the period is the best time. Or within 7 days of the last periods, we can put a copper.
Right. And what about emergency contraception?
Yeah, copper T can be rarely used as an emergency contraception. Also, I talked about it earlier. Also, yes, it can be used as an emergency contraception within 5 days, up to 5 days of unprotected intercourse. It can be kept.
Right. So, any precautions she need to take, the woman? What will you suggest her?
Yeah, we have to, before copper T, the highest rate, though there are a lot of myths associated because it is the most uptake of copper T is so much. So we need to tell them about increased bleeding in first 2 to 3 cycles. Usually it is 3 cycles that it takes to increase bleeding. And yes, we can offer them tranexamic acid for these episodes. And in case the patient already has a history of excessive bleeding, then yes, progesterone containing IUDs can be offered as an alternative to them after explaining the mechanism of action of that and explaining to them the possibility of amenorrhea or periods of amenorrhea and irregular bleeding with this. Because progesterone containing IUDs, the most important reason for discontinuation is the amenorrhea part. So that has to be very clearly explained to the patient that how or irregular bleeding can occur, unscheduled bleeding can occur with these progesterone containing. On the other hand, usually with copper containing IUDs, it is excessive bleeding and increased days of bleeding. They have to expect that if they bleed for 5 days, they may bleed for 6, 7, 8 days. So that is what they have to be prepared for. And usually we tell them if they take tranexamic acid, and hemoglobin also level should be tested because most of our females are anemic. So anemia is one reason. So if a female is already anemic, then she's better to be offered a progesterone containing IUDs because that gives a much better cycle control. And she will also be very happy with it because her hemoglobin level will start rising because of that.
Thank you. Thank you so much. So nicely you have explained everything. The very important thing is that we must counsel these patients. And if you've done very good counseling and you explain to them even the failure rate, which is very less, though it's 0.6 only, but still you have to tell them. See, I had a patient and it's many, many years back, maybe more than 20 years back. I was very young that time, but I had counseled her so well that time also. First copper T she took, that time we had only 3 years duration copper T only. And it was good. Then she said, okay, now reinsert another one after 3 years. So we reinserted. And that time she had a failure. She had a pregnancy. But mind it, she went for abortion with us only. We did her MTP. And she said herself that please put in my another copper T again. So we again put in, and the next 3 years were really fine with her. So if you really do good counseling, they understand the accident or the failure, and they really accept the contraceptive method. So really, Dr. Gitanjali, you really explained everything so nicely. I think people who are hearing, or maybe the public who will hear, they will go for the IUCD session. Thank you so much. And now I will ask Dr. Sonia Naik to please go on with our next very important IUD. Dr. Sonia, your question, please. Dr. Sonia Naik?
So I think
the
progesterone-releasing intrauterine devices has been a real boon to our women, and it's kind of a magic wand for the gynecologist which has come up, not only just for contraception but for so many of our non-contraceptive users. So is Dr. Sugandha there? Has she joined? Dr. Sugandha? So I think she hasn't been able to join. Dr. Amruta, will you be interested in taking up this question?
Dr. Gitanjali was ready to answer.
Dr. Amruta?
Yes, ma'am, I'm here.
Dr. Amruta Jaipuria?
Yes, ma'am, I'm here.
Yeah.
Ma'am, can you hear me?
So let's discuss about this progesterone. Have you been using the progesterone-releasing intrauterine devices? And for what sort of females for contraception?
Ma'am, personally, I haven't used it for contraceptive purposes. I have used it for gynecological reasons in cases of fibroids and adenomyosis. But yes, these are wonderful devices, and
I have experience of using LNG IUS both for contraception and for AUB, and I have been using it from the time that it was introduced into Indian market. So see, there are women who would like to use IUDs, but they have menorrhagia. Like naturally, they have more excessive blood loss during menstruation. So for them, this LNG IUS becomes a very good choice. It says IUD, but it reduces the menstrual blood loss. And another good point about it is there are women who will have endometriosis. They have conceived once and they want a contraception for some years. And this is again a very good choice for them. So for two group of women, those who are having heavy menstrual blood loss, or those who are having endometriosis, or some women even have dysmenorrhea, for them also it is going to be a very good choice. Otherwise also, like in working women, they don't want prolonged days of menstruation or heavy menstrual flow. So because slowly and slowly it will lead to amenorrhea without affecting their health, that should be told to them. So it becomes a very good choice for them. And the price of IUS LNG has also been brought down to 3,250 mostly we get in that cost. And they save a lot with spending that much, because they will be needing less sanitary pad during their menstruation because of the lesser blood loss. So all these things can be told to them, and it is a good choice.
Yes. Correct, Dr. Seema. So absolutely right. And they also have minimal side effects because the endometrial concentration is more than the blood. It's almost like 200 times less in the blood than the endometrium. And as the other progesterone are basically, the kind of action that the other progesterones have, like inhibiting conception, is thickening the cervical mucus and impairing tubal motility. This also has a similar action.
And it prevents ovulation also. So
that is
another beneficial effect.
Because it does not inhibit ovulation so much, because the blood concentrations are too less. So that is not a... Now, there are certain newer LNG IUS also now coming up into the market, like the Fenulus, which has a shorter sidearm device and well suited for nulliparous women. So like nowadays, we have these adolescent girls, and the younger women who are actually, they are working in the corporate sector, they have to travel a lot. Now, if they are taking the pills, they have to be very careful regarding the duration of so like, because the cycle changes from country to country, so it's very difficult for them to keep a track of that. So for them, LNG IUS is really nice, because one, they hardly have any periods, and second, they don't have to worry about those aspects also. And now with the shorter sidearm devices, it's less painful for insertion in these adolescent and the nulliparous women. Now, there's another device called the Fibroplant, which is actually a frameless. So there are certain frameless devices which have come up. Frameless means they don't have the side arms. So therefore, again, removal is also not painful. So these are also available, releasing lesser amount of progestins, containing lesser amount of progestins. So that means for a shorter duration, that is for 3 years also, these devices are available. So as Dr. Seema has already highlighted the advantages. Now, the best part that it can be used in the lactating mothers. So after 6 weeks postpartum, it can be used in lactating mothers without causing any hormonal changes. Whereas if in case they'll be worried about the OCPs, we can't use them in the breastfeeding mothers. So this is an absolute wonderful thing to be used in the lactating women. And again, immediately reversible and ideal for spacing. So therefore, the unmet needs, again, this can be very nicely advised for women who are actually looking at family spacing. Now, disadvantages, this over here, I'm also taking into account the intrauterine devices like the copper releasing also. So a little painful insertion, menstrual irregularities. Initially, we just have to really counsel them well. Counsel and counsel and counsel, that's the most important thing with any progesterone related, any hormonal contraception, whether it's the pills or the injections or the implants or the intrauterine devices. Most important thing is to counsel them about menstrual irregularities for the first few months, especially 4 to 6 months. That's it. And then it's quite stable. Now, definitely no protection against STD or PID. That's one disadvantage that we have to consider. And complications are related mainly is early complications just to the insertion, things like a vasovagal, and late ones again with the copper T, dysmenorrhea or a menstrual dysfunction, and again the STD or the any pelvic inflammatory disorders. Now, Dr. Sugandha is again not here. Dr. Amruta, you can take up this question. Vaginal ring. Have you been using the vaginal ring or the Nuva ring? Or whoever has used the Nuva ring can actually answer this.
I haven't used, ma'am, but of course they are new and they have to be inserted in the vagina, and the lady can do it for herself. And they are loaded with the hormone, a combination of estrogen and progesterone, and they need to be changed monthly. And with the local release of hormone.
Over here, I mean, one, the availability has become a little difficult in our country because it was not being used so much.
Yes.
Now the availability has become difficult. Now this ring has to be inserted on the day 5 of the cycle, and then on the after 21 days she'll remove it. She'll have a cycle again. She'll put it a newer ring on the day 5 of the cycle. So we heard basically the trouble of taking the oral contraceptive pill daily is avoided by this. Suppose it comes out during intercourse or after intercourse or any time otherwise, you just have to wash it and again replace the same ring again. Only that it completes its action after 21 days, but in those 21 days, even if it comes out, you just have to wash it and again replace that same ring. Dr. Anita Sabharwal,
Yeah.
you can take up the pills.
Right. Next. Thank you so much. I think it's going very interesting since we have a full basket of so many contraceptives and one better than another. So now we go on to another very good method of contraception, that is oral contraceptive pills, and known for years together. And every time we are having something new which is coming up. So I will request Dr. Hakim, ma'am, Dr. Seema Hakim, to again tell us about this method of contraception, oral contraceptive pills.
Oral contraceptive pills are combined oral contraceptive or progesterone only pill. So combined oral contraceptive pill has, in our country, what is available is ethinyl estradiol. Along with that, oldest one has gestimate, but levonorgestrel are there. Then some have like Novolon, Familon have desogestrel. Some have gestodine. Gestodine is also a constituent of progesterone only pill. Then newer one has drosperinone like Yasmin and Yaz, and some have cyproteron acetate with it. So any one of them, they can be given, they are effective. But those women who have more androgenic effect like hirsutism and acne, they have a better choice of taking cyproteron acetate containing pills. One advantage of giving, if we want to add more cyproteron acetate for hirsutism and acne, and we want a better effect, in that in the reverse sequential order, we can add additional cyproteron acetate, which is available as AndroCure 50 milligram tablet that can be added in the first 10 days. So that is the advantage, especially as we are getting more and more cases of PCOS. And they need contraception as well as they need the effect on their acne and hirsutism. CPA with ethinyl estradiol is a good choice for them. So when we are prescribing OCP, so in family planning, we have Mala N. So most of the cases who are coming to our hospital, they are provided with Mala N, which is free of cost. But if somebody is wanting to go for some other pill, they will have to buy it from the market and it should be made clear to them. Then if they take properly these pills, they are very effective and the failure rate is less than 1 per 100 women year. And if somebody is forgetting all the time, then in that case, the pregnancy failure rate becomes higher, even up to 10 per 100 women here can be there. So how to tell them that this is safe and they can go for it? If there are no contraindication, like they do not have a thromboembolic or deep vein thrombosis in the past, they do not have a liver disorder, or very obese women likely to have hyperlipidemia. So in those cases, it is safe. And always remember that in a younger age group, these diseases are rarely there. So most of the younger population will be fit for OCP. It is said to the extent that you need not to investigate them even, and you can prescribe even the paramedical or peripheral health worker, they can advise OCP. Sometimes, if you suspect that this lady had hypertension, like many times, they tell us that hame lagta hai ki blood pressure hai. In that case, you need to measure that blood pressure, and if it is there, then they may have to, you have to be cautious, or they may have to go for other contraceptive devices. Then how can they be sure that they are taking it every day? So you can tell them that you go to bed every day. ये तो नहीं कि तुम कभी सोती हो, कभी दिन में सोती हो, कभी रात में सोती हो. तो अगर रात में सोती हो, तो just before going to bed or brushing your teeth, you can take this pill at that time, and then you can go to sleep. So every day they will remember from that packet that they have taken it. And side effects are very minimal, and after 2 to 3 months of taking pill, the side effect will also go on. Then another important issue, like many a times I tell my client, because the working women, or even if they are not working, it is not always necessary to have a period every month, that they take it for 7 days, 21 days and 7 days gap, or 28 days, like during that gap period, they have a withdrawal bleeding. So extended use is also very much recommended. With that, they have only 4 periods in a year. So if they are having every time they are going for a withdrawal, they need 13 packets in a year. But if they are going for withdrawal only 4 times in a year, then they might need 15 to 17 packets in a year. So we can advise them, and that helps them a lot. Like they have some event and they go on taking it, like our ladies, they are going for Hajj or somewhere, so they can take the extended tablet, or girls having their exams, or they have some other commitment, so they can take one after the other pack. With those who have iron 7 tablet, that has to be discarded.
Thank you, ma'am. Thank you very nice.
Can I add something?
Yes.
I just wanted to add this thing that nowadays many of the young girls smoke. So if you're prescribing it to young teenagers, that is very important that they should be, his smoking history should be taken. And also even to young girls, do explain the side effect, because I have faced this in a young girl. She had venous thromboembolism. She was put on cyproterone acetate combination, and she had venous thromboembolism. So very, very important to explain this thing, if they're smoking or not, to take the history. And also sedentary lifestyle has to be avoided, because most of the young girls are couch potatoes. Sedentary lifestyle also predisposes them to VTE. So that also has to be explained to them, that lifestyle modification and not having a sedentary lifestyle is very important.
Right.
Because
And
I've seen it in a young girl.
Young girls, they have multiple sexual partners also. So even condoms should be added on along with the pills.
For STE, that also can also be explained. Yeah, condoms should be for.
And also they should know not to take it any time, because they think they can take any time of the cycle. So they have to take either on day 2 or day 3 of the cycle. That has to be explained to them. So maximum up to 5 days.
Actually, for younger girls or for unmarried girls, they need to be counseled on many aspects.
Absolutely,
it's not just the contraception that we are
complete contraception.
So this becomes a totally different topics then, because
absolutely
when they fall in all these activities, they lose their focus of studies, and also I think their counseling becomes a totally different.
I think we write the prescription maybe in 5 minutes or so, but 50 minutes are required for counseling because you have to really take into each and every aspect.
Yes,
when you
very true.
counsel
Very
them.
true.
Yeah. Thank you, ma'am. Very nicely done. And now we are going further with Dr. Sonia Naik. Dr. Sonia, please go on with your next question. We have to do fast now. We have the last
Yeah,
4
I
5
think
minutes.
we're time because very less time now for the case discussions then.
Yes.
So, Dr. Vartika, are you here?
Yes, ma'am. Good evening.
Yeah. So, basically, I just wanted you to tell us how frequently you've been using DMPA for contraception and what are your views about DMPA and what are the advices that you give to a person and which population that you would like to use DMPA?
Ma'am, DMPA, yes, I'm using. And most commonly, like patients themselves come and they demand for this contraception. I have found it very useful in post-abortal cases also, because once a patient comes for MTPs or for abortions, and then if you give the shot at that very time, if patient is not able to come, for contraception in another month, in spite of telling, because I am in a rural background, I'm practicing here in the rural place. So, I get that opportunity at least for 3 months. She has got a birth control because DMPA is readily available with us. And this injection is given every 3 monthly. And though combined estrogen progesterones are also injectables or there, but they're not readily available in our part. And I give her anytime if she comes for a regular checkup, regular clinic. So I ask her to come within
That's an
5
important point which Dr. Vartika has brought about. She can give it at any point of time.
Yes, she can take any time. And if after birth, like if my patient is coming, if she is there, I counsel her that you have to breastfeed first your baby. And I tell her at that very point that after 6 weeks, you can come to me. 40 दिन के बाद 6 हफ्ते के बाद आप मेरे पास एक विजिट के लिए आओगे, तब आपको ये डिम्पा इंजेक्शन I can give it to you. And in abortion cases, I am giving her regularly, and I counsel her, ठीक है, if you take this injection, there are chances you might have irregular spotting, some bleeding irregularities might be there, but don't worry, this might happen with this injectable, and some weight gain, tenderness, and mood swings might be there. And if you are taking it regularly over a period, say for 3 to 6 months, and if you're taking it, you might have a period of amenorrhea. So she should not bother about it. So she should come, and with the regular checkup, that thing can be taken into account.
Have you noticed any changes in the bone density?
Yes.
Or do you really actually advise them also in the adolescent age group?
No, I'm not. But yes, in bone density, if they're using for more than a year, though I haven't, my regular clients, I have not seen that they are coming regularly, that long. So, but yes, bone density does decrease. So we should advise her to take calcium supplements along with this, because more chances of osteoporosis and bone thinning do occur with regular intake of injectables.
Fine. So Dr. Vartika has nicely pointed out all the side effects, when to start, what are the other benefits that a woman has with this, and which population that we should actually use DMPA more in. Now, talking about the implants that we have, Dr. Amrita, can you just tell us about, in our country, we have the implant now, which is the Implanon.
Implanon is there. Yes, ma'am.
And have you used that?
No, ma'am, not yet, but of course, yes.
Has anybody used, because they'll be the better people to actually answer these questions about the implant, because it's very interesting to know that in our country, although we have the Implanon NXT now, almost for a few years, but still the usage is very, very, very low.
Even in government sector, they have got them, but still they need the training is to be done for the doctors. So that is still pending.
Insertion
So,
is
yeah,
quite easy.
yeah.
Yes,
Yes.
Dr. Abel?
Yes, ma'am. It's implanted. It's a 4 centimeter long and around 2 millimeter in diameter device, a rod-like structure, and it has to be implanted subcutaneous below the skin, and it has around 60 to 70 milligrams of this thing, etonorgestrel, and the release is higher in the first year of use, around 60 to 70 microgram per day, and it goes down in the third year to around 30 micrograms per day. It is effective for 3 years only, and
So
it's an
basically,
OPD.
Yeah.
OPD procedure, yeah.
Yes, ma'am. It's an
Yeah, it's
OPD
an OPD
procedure.
procedure. Just give a little local anesthesia around 2 centimeters above the elbow on the lateral side of the arm. And one has to just see the dip between the triceps muscle. And then over there, you just insert this. So there's basically, it's always better to have a training and then do it, never do it without. So then you know how to place the rod inside and how to remove the plug.
Remove it, yes.
So that's always better, but insertion is very easy. Removal can be a little difficult.
Yes.
So especially if you have put it inside a little deeper, then you really have a tough time. Otherwise, also after 3 years, there's some fibrosis around the implant, and sometimes to catch the implant, remove it, you have to be a little, I mean, you have to give sometimes even 15 to 30 minutes depending upon the removal time. So that's this.
Right.
But in the same effects with this, about the progesterone, as with the rest of the progesterone releasing devices, the same effects, same side effects that one has. And so therefore, talking about the long-acting reversible contraceptives, we have the copper T, the LNG-IUCT, the implants, and the DMPA.
Right.
Dr.
So,
Nidai.
yeah, so next question goes to Dr. Shweta Mathur. So now we come to the permanent methods of contraception, which in our country, women are supposed to take up, and whereas the males, the contraception, which is for males, the male sterilization, which is easier, they are not taking it up. So let's see what Dr. Shweta says about female sterilization.
Thank you, ma'am, for the question. So female sterilization is actually quite popular in our country, and the minimum requirement will be to have at least one child more than 1 year old to go for it. And we have to tell the patient that it's a permanent method, and although reversal is possible, but it will require a major surgery, and the success rate is not good. So she should finally make up her mind and then go for it. So puerperal is very good option that we can tell the patient during pregnancy also, if it's a third child especially or more, that the uterus is up in the abdomen. So it is very easy to perform than to perform it later. And the resting time after the delivery can also coincide with the resting time after this surgery. So it can be done 24 hours after delivery to up to 7 days of delivery, but it should be avoided if there has been a lot of blood loss or there was chorioamnionitis. If there is any negative feature, like if patient had eclampsia, in such cases, we should avoid, but otherwise we can go ahead and do the puerperal ligation. And similarly, post-abortal also, we should encourage our patients that we can do a simple mini laparotomy, and it can be done easily. And the techniques will be Pomeroy's method for the open method, and elastic band for this, the special laprocator is required for the ligation. So mostly private hospitals are not having it. So government setup only, they are doing it with this elastic band. And laparoscopic, mostly we do in the private setup. We just need to inform the patient that there'll be 3 small cuts, horizontal, and then we can do the ligation. And we should always send the sample for medico-legal purpose. we have to always tell the patient that sometimes, very rarely, pregnancy can happen, and especially an ectopic pregnancy chances high if there is a pregnancy. So if there is any problem, patient should always report to us. And for the Pomeroy's method, we should try always do the ligation with around 2 to 3 centimeters away from the cornua, so that it is the isthmic area, and the chances of recanalization, if required later, will be easier. And while doing the ligation, we should always follow the tube till the fibrial end, and we should confirm it that it's the tube only, and then we can do. So hysteroscopic sterilization, I think Assure system used to come, but Bayer has stopped selling it in
Yeah.
2018. So I'm not sure if
Yeah, now it's not in use. Yeah.
now it's not being used.
Yeah. And also they used to say after that 3 months.
3 months, yeah. So they have to do an HSG to confirm whether the fibrosis has happened, and the ligation,
Quite a complicated one. Yeah.
yeah.
Right. And also the government is, authenticating these centers. And so if any mishap happens, like if there is pregnancy failure is there, so government is helping those people, like government pays for them. Yeah. Even the facility, the hospitals. So they have to be accredited
So
by the, So they are promoting actually. So that's a good idea. So thank you so much. And now we go on to the next question to Dr. Shalini Tandon ma'am for the male sterilization, which I think is the need of the hour, and it should be the talk of the town. And most of the males, like, they should go for it. I don't know if they are just scared, or the taboos, or our culture, which is saying. My own radiologist, ultrasonologist also, he's a marathon runner. He got his vasectomy done. And we were so proud, and he had 2 daughters. So and he's so fit and fine, he's a marathon runner.
And we need a brand ambassador for that.
Yeah, yes, I will now make him. We just honored him in our last CME on 7th, Dr. Vikas Bajaj. So it's a, very nice method. So let's see what Dr. Shalini Tandon ma'am has to tell us. Ma'am, Dr. Shalini, are you there? Dr. Shalini ma'am is probably not there. So I think Dr. Shweta, you can go on in a very
something about male sterilization.
Right, ma'am. Yes, ma'am.
Shalini is there. Shalini is there.
Yes, ma'am. Please tell us briefly about this male sterilization.
Few points only I would like to say regarding male sterilization. It is a permanent method of sterilization. We all know that. So very important, and it is very less opted in our country. So what is more important is pre-sterilization and post-sterilization counseling is very important in this way of contraception. And for pre-sterilization counseling, we have to select a right person, a right man who at least is above 30 years of age and is healthy, and at least has had 1 child and is married. So that will be then ideal person, ideal candidate for vasectomy. And then we have to counsel that person that sterilization is going to be a permanent method, and after that he will not be having any chances of fatherhood, and then the only chances which will be left for him for fatherhood will be, if his mind changes, will be by in vitro fertilization, and which is also a complicated method, and success rate is also less. And recanalization in case of vasectomy is very complicated, though vasectomy is a very simple procedure. It takes only few minutes to do it, but recanalization after vasectomy is very complicated. So the person should be thoroughly and mentally prepared before he opts for vasectomy. He should know all pros and cons of it, and then he should be counseled properly, and he should be offered a vasectomy. And he should be counseled that after vasectomy, he is not going to be disabled in any way. He will not be, his physical activity, his day-to-day activity will not be affected. As such, you very rightly pointed out one marathon runner. So he must be running with that same speed after vasectomy also. He must be very healthy. And
he's in day by day.
He's
increasing his speed day by day, ma'am.
His speed day by day. Counsel, whatever, many times the men have fear that they may have loss of libido by this vasectomy, and they may have some erectile dysfunction. So we have to counsel them that this is not going to affect in any way their sexual activities and neither their physical activities. They will have to abstain from their work, from their profession only for 1 or 2 days. They don't even need to take a lot of rest after this vasectomy.
Right.
So these things are to be emphasized to them, and then we can mold them, we can encourage them to go for this.
Yeah. And only thing is they have to take precaution that for 3 months they have to have
that is
abstinence
very
because-
important that after 3 months they have to take a backup method whenever they are going for any sexual activity, and after 3 months they should get the semen analysis done, and until it shows complete azoospermia, semen analysis should be repeated again. If the semen count is not low, it should be repeated every month till 6 months. And even if after 6 months the semen count is there, then it means that vasectomy has failed. The properly is not being vasectomized. So these are the important things which have to be counseled.
Absolutely. Thank you so much, ma'am. I think we've had a very wonderful.
Actually, vasectomy part is mostly done by our surgeon colleagues.
Yes.
We don't do it. So it's
But
more
like
for
in the
them.
government hospitals,
we
ma'am,
have to
they
counsel. Counseling we have to do.
absolutely. That we have to do, and in their own center, in the family planning department of the hospital, they call the surgeon there only. So patient is yours, everything is yours. He's just a visiting surgeon who does the vasectomy. So so thank you so much. But I would just like to tell you about one patient who just came to me day before. Such a sad story, because this lady is in Delhi. There's 5 karamcharis. They just came looking for me because somebody knew me. So first they gave me a history that they have 2 children, and due to her lactational amenorrhea for 1.5-year-old child she has, so she just detected a pregnancy. Now she was 10 weeks, and her hemoglobin was only 5.1 gram. And later husband came and told me that he's telling you lies. We have 5 children. So this is the sad story that, see, even lactational amenorrhea, they don't know properly. They think that she hasn't had a period. So even 1.5 years, they can go on like that. And then they, even staying in Delhi, they could not go for contraception. And look at the state of this lady with 5 children, 5 gram hemoglobin. And the man still was saying, oh, now with 5 gram, you can't do the MTP. So then don't do anything. No investigations required, nothing. So that is the status of these people in our country. So anyway, now I have sent her to the tertiary center, and I hope things will be looked after. But that is the poor state, sad state. So Dr. Sonia, sorry I took your time. Please go on.
We have time for this case scenario. It is 5 minutes.
But फटाफट से कर लो, 2-3 जो आप लाए हो तो quickly कर लेते हैं.
Okay.
Dr. Malhotra is there. Dr. Malhotra, sir. He was saying he'll join us. Dr. Malhotra, Dr. Narendra, sir, you are there. So you go on with the questions fast.
Okay, so Dr. Vartika, this is a case wherein 28-year-old primary grammar is being counseled for postpartum family planning, and she's not planning on breastfeeding. Now, what are the options available to her postpartum? An IUD, a progesterone-only method, or a combined hormonal method?
Yes, ma'am. She's 28-year-old, and first of all, she is not willing for breastfeeding. I would counsel her that she should breastfeed her baby, and will explain her all the advantages of breastfeeding. In spite of that,
she had some problems for which she's not feeding, and let's limit our discussion to this.
Yes. So I will explain her that as soon as she delivers, then within 48 hours, she can go for postpartum intrauterine contraceptive device insertion. So that is a very good method. And if she doesn't want to breastfeed, then even progesterone only pills can be given to her, or injectables can be served to her. So these would be a very good option if she is not planning to breastfeed her baby.
Yeah, so basically, in case we take it as less than 21 days postpartum, CFCs should not be used. Progesterone-only methods can definitely be started. Intrauterine devices and the time of the delivery or the cesarean can be inserted. Now, 21 to 42 days, if there are any other risk factors for VTE, again, CHCs should not be used. And without other factors, CHCs can be used between 21 to 42 days and beyond 42 days very safely. But whereas the rest of the methods can be used even before that.
Right. Next question.
So next question to Geetaji.
Dr. Seema ma'am wants to leave. So ma'am, it's your wish if you want to stay for, we just have 3 more.
I told you we have a wedding in the family.
I know, ma'am.
So everyone is waiting for me.
I know, but we are also enjoying your company actually.
I am also enjoying it. That's why I am asking how long.
Now, just 2 questions more. Two scenarios. That's all. Chalo quickly kar lete hain, Dr.
Dr. Geetaji, 38 years old, para 2 with diabetes, has been using barrier contraception, now looking for a more effective method. So what methods are safe for her to use, knowing that she has diabetes?
Yeah, so IUD can be used by her if she's well controlled diabetes. IUD is a good method to be used by her. All the other methods, if we look at the LNG again, if she has vascular disease, then she's not advised to use that. Progesterone and hormonal contraceptives, she may not be very keen. She's already taking medicine, so IUD is the best that she can use with it. So that will be the best.
Very simply that we can put it down, like anything which diabetes is associated with vasculopathy, avoid using hormonal contraception, especially the CFC. Even with the progesterone only pill, you have to counsel them about the arterial thrombosis, not the venous thrombosis. That you have to be careful about it.
Right.
Now, Dr. Shubha Pandey, 30-year-old female, history of migraine headaches with light sensitivity, does not experience any visual signs of a headache coming. Now she is interested in starting contraception. What are the methods that you can do for her?
Combined
Now, according to the medical eligibility criteria, a woman with migraine without aura, she can use copper intrauterine device. She can use LNG IUD. She can use implants.
Correct.
Strong methods. They are all category 1 methods and they can be used safely. Now, combined hormonal contraceptive are category 2. The benefits outweigh the risk of the unplanned pregnancy. So if she doesn't have an aura, but she has risk factors for stroke or thromboembolism, like she has migraine with focal neurological complications, or ischemic heart disease, or history of smoking, hypertension, venous thrombosis, has diabetes, or has had major surgery, or may need to be immobilized, or she gives a history of menstrual migraines, then only intrauterine device or progesterone only pill should be given. Because in these cases, the combined hormonal contraceptives are not, they are contraindicated.
Correct. Absolutely correct.
Absolutely.
So now coming to the next scenario, Amrita, 19-year-old sexually active girl who wants an IUD, and she had a history of chlamydia 6 months back, and she was treated for that. Now she has another new partner. Now, given her STD risk factors that she has now, can you place an IUD today?
No, ma'am. I mean, she should be counseled first, and she should be told about the use of condoms to prevent further STIs. And since she, as she has multiple exchange of partners, she shouldn't be doing, she shouldn't be like having contacts without condoms. And if she has current infection, her vaginal swab culture should be taken. She should be properly examined. And if she is having infection, then IUD should not be inserted. And she should be treated.
If she has any current infections, it should not be put. But even otherwise also, you should take a swab for chlamydia and gonorrhea. But rest of the methods, yes, if in case we are advising her the rest of the methods, we should always also explain her about the concurrent use of the barrier contraception. Absolutely fine, Dr. Amrita. Now, coming to the last scenario, 26-year-old who has been using combined oral contraceptives for 1 year calls you to ask whether it is safe to start taking sertraline for depression. What should she do? So basically talking about OCP's use versus and with SSRIs. Dr. Shubha Pandey.
You can answer. Yeah. You can answer, Dr. Sonia.
So basically any SSRIs and OCPs, there's no problem. They don't interfere with the liver function or with any other enzymes. So over here, they can be used concurrently. So thank you all the panelists for the expert opinions. And we had a wonderful panel discussion. Thank you.
I hope our expert is here or not. So anyway, still in his absence, we would like to thank him also. And so there are two powers in the world. One is the sword and the other is the pen. And there is great competition between the two. But there is another third power which is stronger than both of them. And that is woman. So the women, again, I like to say Happy Women's Day. And through these women today, who were our panelists and who were the our great teachers here rather. So I will say through them, we can save so many precious lives of our women. And through this contraceptive usage and by imparting the awareness and knowledge to so many women in our country, we can really do a lot of wonders. So we have learned today, starve the problems and feed the opportunities. So the moment a woman comes, we should be ready to offer a contraception. And the cafeteria approach will be really, truly taken up if we don't let any woman go hungry of contraception. So let us all join hands and say Happy Women's Day to each one of you.
Happy Women's Day. Happy Women's Day. Thank you for including me, ma'am. Thank you.
Thank you all.
Thank you.
Thank you, Anita ma'am, Sonia ma'am, for the excellent deliberation. Thank you, heartfelt thankful. Thank you to all the panelists, Anita ma'am, Sonia ma'am, for the excellent deliberation.
Special thank you, Sonia Naik, because just in 1.5 days, she joined me and she's busy in Max. Even now, she was busy in OT till 4 p.m. So thank you so much.
Take us out of the situation. Thank you.
Thank
you so much.
Thank you.
All
Bye.
the beautiful
Bye. Happy Women's Day.
Bye, ma'am.
Thank you.